Oh, I'm sorry. I'm sorry. I
Okay.
had put myself on mute. I was not, paying attention to that. Yes, we'll be going live shortly, on YouTube as well. So I would take this opportunity. We are already 3 minutes. Yes, we are 3 minutes into the session already. So I think we'll start with the session. I'll take this opportunity to introduce our first speaker, Dr. Vishal Rao, who's already joined us. So, Dr. Vishal Rao is presently the Dr. Vishal Rao is presently the Regional Director, Head and Neck Oncology Unit and Robotic Surgery at Healthcare Global, based in Bangalore. He was actually the inventor of Om voice prosthesis. That's like almost like a $1 speaking device for throat cancer patients, and he's very actively involved in anti-tobacco initiatives. That's one of his passionate areas, apart from the surgical interest that he has. The other aspect is that he is also involved in academia. He's an academician who's also heading the academic unit at HCG. So I wouldn't want to take too much. Actually, there are lots of things that could be said. He is also serving as the member of a high power committee on tobacco control, Government of India, and he's also a part of the advisory committee to the principal scientific advisor, Government of India. So he has also been conferred honorary FRCS by Royal College of Surgeons, Glasgow. He's a recipient of the Judy Welkenfield Award for Global Excellence in Tobacco Control in the year 2017, and a lot of awards have been conferred on him. It would be a very long list. So we welcome you into this event. And one thing what I want to say is that the first instance when I sent a message to him, asking if he would be willing to join us, he was very enthusiastic about it, and he agreed to join us instantly. So we thank you for that, sir. Uh, Sir, the now I'll just leave the stage for him to take over.
Thank
Sir,
you.
just a
Thank you,
minute.
Dr. Karthik.
Yes, sir. Yes, sir. Have you been given the? Yes, sir.
No, not yet.
Yes, yes, sir. I think you should be able to stream shortly. Just let me know, sir.
Yeah, I think I've been given the
Yes, sir.
rights.
You should be able to share the screen right now, sir.
Okay, let me just check where is my screen.
So, an introduction to the topic is that we were discussing with him as to what aspect of evidence-based healthcare we will ask him to talk on. So he said, he's passionate about the education aspects as well. So he said education and research are the pillars, the other two pillars of healthcare. So he suggested that he would like to talk on research as a career in the era of evidence-based healthcare. So over to you, sir.
Thank you. Thank you, Dr. Karthik. And I congratulate the team of JIPMER that has taken this enthusiastic effort on the Evidence Based Healthcare Day to touch upon such a less, I would say, emphasized topic, such a less discussed topic. And I personally, I must tell you, when Dr. Akilesh wrote to me, I actually felt a heartfelt appreciation for the efforts of a small group that has actually taken a leadership to have even ventured into this subject. And it's very, very interesting. And in the next coming slides, when we both exchanged together some of our notes, we discussed about why we should take up some things, and I requested him if it would be okay if I can take up on this topic, because this is something very dear to me, and I'm going to share with you about why I am talking on this, what are the key areas that I'm going to talk about in this coming few slides. Now, the larger intent of this presentation of mine is to talk to you about the need to recreate a sustainable translational research to advance patient outcomes. I think for me that I just wanted to put a gist to this entire thing to justify what I'm going to talk in the next coming slides based on this particular discussions. Now, I would like to again reiterate that I'm representing HCG. HCG is a chain of cancer centers. We are primarily focused on cancer care, but we also have a presence briefly in fertility. We have a separate wing of precision medicine called Strand, which works on bioinformatics, diagnostics, and also has a clinical research organizational wing. We also are into the multi-speciality area in a very, very small way with three multi-speciality hospitals. We currently are at about 26 centers across the world with the recent entry into Africa and Vietnam. And we went public in 2016. Our model of oncology has been something that has been studied by the Harvard Business Review as a case study also, to look at how we can give quality outcomes which is equivalent to that of the global standards. So this is just a little bit of a gist of our organization. I also spearhead the wing of research and academics for collaboration. So we run a joint program of fellowship with the Royal College of Surgeons of London for our head and neck surgical oncology program. I'm also the editor of the Journal of Precision Oncology, which is something that we have jointly initiated with Walter Clovers, and we run joint programs with Nature publications on scientific writing. So these are some of the broad things that we are currently doing in the academic area. We run our own courses, which is certified by HCG and some by the university and the national board at HCG. So we are close to about 140 students. That's just a brief background to the discussion that I wanted to do and introduce myself. This was a very relevant, interesting paper that came out in 2000. Around that time, I was also visiting John Hopkins, and this paper came out from there. It was a very relevant, thought-provoking paper. Is U.S. health really the best in the world? And this particular paper brought about some very, very thought-provoking discussions. They looked at mortality ratings across the world. I mean, they primarily focused on US, and they looked at mortality rating in United States, and they found that the first contribution came from cardiovascular diseases and the second contribution came from heart diseases. Can anybody take a guess and tell me which was the third one? What was the third contributor? You can just put it in the chat box, and then maybe the moderators can tell me what the answers were. What is the third one? What was the third contributor for mortality in United States? Take a guess. Is Akilesh there? I think it's Akilesh. No,
Yes, yes, I'm here.
Akilesh.
Yes, I'm here. I'm here. I
Akilesh,
am.
if anybody has pointed which is the third important cause of mortality in the United States as per this paper. If somebody has put some answers in the chat box, please let me know. I'm not sorry. I'm not able to access the chat box.
Uh, I think we have to give them a couple of minutes to warm up to the question.
Sure. I would request the participants take a wild guess. There are no negative markings, and if you get a correct answer, Akilesh will give you a separate prize.
Oh yes, why not?
Yeah,
Guys, come on. Uh, Dr. Karthi, you would like to take
Any
a
answers to
shot at
this?
it? I
So
think the
this is
host will
I
have
just
to take
wanted to
over.
tell you, doctor was the third leading cause of death in this paper. So
Medical negligence.
12,000 unnecessary surgeries, 7,000 errors, 20,000 other errors, 80,000 infections, 1 lakh non-negative effects of drugs. So close to a total of 2 lakh 50,000 deaths per year from iatrogenic causes. Am I
Uh,
audible?
yes, yes, you are. I got a private response stating medical negligence as the third cause. Yeah.
Correct, correct. That was close. Yes. So doctor is the third most leading cause of death. And when I reconnected with this group a little later, they told me no, no, that was old data. Now he's at the top. So I think this was a eye-opening paper that actually talked about this is not where we want to be. This is not where we want the globe and the world to look at us as a leading cause of death. I mean, for me, this paper was just a little eye opener to talk to us about what is the implication
நம்மளது
of health
என்ன
today.
மார்க் ஃபோர்த்
And
செமஸ்டர்
what I wanted to re-emphasize through this was evidence-based medicine, risk communication, and medical legal litigation are considered to be the three hallmarks of the 21st century medicine. It is prudent, essential, and vital that we embark on understanding these three to shoulder the responsibility for the next generation of medical experts, medical healthcare workers who are going to come into this field. I would again try to reiterate the three hallmarks are going to be evidence-based medicine, risk communication, and medical legal litigation. Now, these three are so deeply interlinked and connected with each other that one cannot coexist without the other. And that's why I so nicely put risk communication in between evidence-based medicine and medical legal litigations, because that's the bridge between the two. And I'm again re-emphasizing, especially for the interest of my younger colleagues, that this is going to be very, very prudent. Now, why am I talking this today? And in this day of this evidence-based healthcare day, I think there couldn't have been a more better day for me to re-emphasize the emphasis and the importance of these 3 points. So I'm gonna open up this thing with another very interesting story that I came across. It's a very interesting anecdote about how do I find a problem. On a lighter note, this particular pictorial has a lot of understanding in it. So there was a cola head of marketing for the Gulf area. He was sitting in Dubai in one of those fancy pubs, having a drink with his friend one day, and talking to him about how he's going to disrupt the market of the Arab countries, how he's going to disrupt the marketing of the Arab countries by a very innovative model. So he was posed with a very relevant problem. He was told to cut the language barrier for cola marketing in the Arab, and his target was in the next quarter he should have every single potential Arab holding a cola in his hand. So he was sitting with his friend in this fancy pub, discussing with him about how he's going to disrupt the market of innovation for the cola markets in the Arab countries. So he came out with a very innovative solution. What you're seeing in front of me in the slide is three pictures. He said, I'm going to cut the language barrier through a very interesting, simple pictorial. A man lying dead tired on a desert drinks a cola and starts to run. Simple. He said, cut to chase. I want to change the game and I want to have every single Arab with a cola in the next 3 months. Time passed by. Couple of months later, they both again met. This time, this friend of ours, the head of marketing, was looking a little dull. He was looking a little depressed, and his other friend, who met him a couple of months earlier, listening to his disruptive plan, asked him, "How are you doing? And how are things?" On a lighter note, he said, "I think you must be the CEO of the company, considering the disruptive plan that you are already programming." Dull and dejected, this gentleman turned to him and said, "Sorry, you know what happened? I lost the job. I was thrown out of my job." This friend was a little surprised. He said, "What happened?" He says, "I thought you had a very disruptive, very interesting plan." He said, "I made one miscalculation. I forgot to take into consideration that the Arabs read from right to the left. That changes the game." And that's what happened. So he changed the game. He released this ad, and he forgot to consider that Arabs read from right to left. So the interpretation changed from a man running who drinks a cola and falls dead in the desert. Now he was thrown out of the job. I'm just giving you this simple anecdote to tell you that today, a lot of the times in research, the fundamental question is wrong. And I keep reiterating this to a whole lot of people who come to me and say, "Oh, sir, you know what? I'm working on this brilliant research project. We've already worked out on this." I'll give you this classical example of a group that came to me and said, "We worked on a particular area of an instrument that we wanted to research on to build for a particular biopsy technique. And we've already built the particular instrument. We wanted you to look at how we can start using this effectively." And I asked them, "Have you met with the domain experts who have actually been using this biopsy process?" They said, "No, we've actually not met with them." I said, "Then how did you come across this problem?" "Oh, we just Googled a couple of things up. We looked at relevant problems. Then we looked at the potential markets. And then we said, oh, this is a great area of research." That's what happens to a whole lot of them. The problem doesn't get defined. And because the problem doesn't get defined, you realize that you're on the wrong track. And I think that is where it is very, very prudent for us to pick up the right amount and the right question. And I remember I was spending some time at one of the genetic labs when I came to Bangalore more than a decade back, and I met a very interesting gentleman. On the day one of this in the institute, when I was meeting this gentleman, I asked him, "So what do you do?" And he said, "Nothing." And I said, so how long have you been doing nothing? He said, for the last 3 years. And I said, that's quite interesting. I mean, you've been doing nothing for the last 3 years. So he said to me, no, you know what? I've been searching for a question. Last 3 years, I've been searching for a question, but I haven't found a good one. So this gentleman in this particular program on PhD was searching for a question for 3 years. He couldn't have found one. He was just hanging around there every day working, but not found his question. My friends, this is very, very important. Today, a decade later, when I talk to this gentleman, he's in one of the top universities in Europe and doing something phenomenally good for himself. And I feel proud listening to the fact that 10 years back when I met this gentleman, he had actually told me he hadn't found the question. Years later, he found his question, and today he's doing what he's doing. Now, I've always said this, that when you look at the apple, you can look at it in many ways. When Newton saw the apple, he saw the laws of gravity. When Steve Jobs saw the apple, he gave me this Mac computer of mine, which is not compatible with most systems at most of the times. So each one can look at computers, questions, anything in a unique way. So look at your problem in a unique way, and that's the fundamentals of research. So when one of the students sometime in one of my presentation came and asked me this question: how do I get a brilliant idea? And I told him, if you hold on to one patient's problem or one science problem for deep enough, you will realize you'll be flooded with ideas. So always look at individual problems rather than markets. A lot of the times our mistake is that we look into markets, and that's when we go wrong, because individual problems can become and translated into masses, which can become markets, but not the other way. And that's why things go wrong. So the one of the important messages I wanted to give through this was that we are not constrained by the discipline of rigor, but by the limitations of our purpose to make a difference, which is defined by our imagination. And I think that is one of the fundamental tenets of research which has not been emphasized well enough. Just another question to each one of you. I call these guys the nine musketeers, and you know what interesting things they have in common? There were two interesting things they have in common, these nine musketeers. Akilesh, again, I would ask that if you can take a toll, Karthi or Akilesh, if you can take a toll and tell me if anybody's got the right answer on this. They have two things in common. These nine musketeers have two interesting things in common. If somebody can take a wild guess and tell me what those two things are. Any answers on that? I hope I'm audible. So
So
I'm
you're
just
audible.
going to
You're
pose.
audible. You're audible. You're audible. You're audible. I think they're waiting for a hint or something.
Okay, so I'm going to the hint is the answer itself. So these were surgeons and they were Nobel laureates. I'm just wanting to share this with you because I mean it's been quite some time that medical area, especially clinical medicine, is actually backing awards in terms of a Nobel Prize, and I'm wanting to reignite this fire in our youngsters, especially to tell that just imagine these nine musketeers were nine surgeons, nine Nobel laureates. And I'm biased towards surgeons just because I'm a surgeon, but I'm just on a lighter note saying that clinical medicine actually needs to relook at this. It's been quite a while that clinicians need to be front-ended in the area of Nobel Prizes. And that would be my moonshot to actually look at and understand when will clinicians again come back into the area of Nobel laureates rather than only basic science. And that brings me to the next discussion that I wanted to do here. My friends, these were inspiring nine, and if you can pick up any of their stories, nine of these gentlemen, and pick up any of their stories on the Nobel Prize, it is absolutely astounding and refreshing. And what I wanted to reiterate through these nine people was they were a very interesting connect between research and innovation, and that's something that I'm going to touch upon in the next few minutes. But these nine examples are something very inspiring for each one of you all to read. Now, this is another disheartening fact that when you look at translational research from bench to bedside, it takes around 17 years. From the basic sciences, which includes preclinical studies, animal research, to clinical studies with phase 1, phase 2 trials, and human clinical research after that into phase 3, and then getting into clinical practice on an average can take as much as 17 years. Yes, that's the truth of it. And here we look at these T1, T2, and T3 parts, actually talking about how this is so vital in today's time and era. Why I am telling this to you is, in the current period of the corona pandemic, we've seen that this particular time actually became a research practice hyperloop. And this is something I keep discussing with the LGBS team and the regulatory authorities in the government here, to see how did we actually jump this from bench to bedside to practice in such a quick period of a hyperloop. So during this COVID-19 period of the pandemic, as though time contracted and the 17 years had become 17 weeks, 17 months, which is very, very interesting, because how we were able to bridge this entire innovation forum into such rapid innovations, that taught us that it is possible to look at several aspects of this. And today, the one single message that comes out of COVID-19 pandemic for the medical fraternity is that research and innovation are interconnected. Research and innovation need to come on the common platform and merge together to bridge bench to bedside medicine. And I think this is a very, very powerful learning we've got from the COVID 19 pandemic today, of how this particular pandemic created the research to practice and innovation hyperloop. So with this entire thing, I think this journey also is important from a researcher to clinical patient. So we've actually formed an association, and I'll again urge Dr. Akilesh and and the team to maybe join hands with us in this society called the ATRO, Association for Transitional Oncology in and Research, where we are actually looking at bridging bench to bedside medicine and taking bedside to bench medicine, and looking at how do we build about as hyperloop in this kind of scenarios, and look at already evidences and bringing them to the forefront. Now, this is a very funny one that I actually came across. This is just for the enthusiast to tell you what are the professions that of the future that already exist today, which means you may imagine that these are the potential professions that are going to come in the future, but as of now, they're already there. Drone runner, medical clown, chief belief officer, chief dreamer, epigenetic counselors, and ethical health data hackers. These, my friends, are current professions that are already there in the systems, in organizations, institutions, and markets with industry. Isn't that interesting? How many of you all have heard even one of these professions? Most of you all would agree that you haven't have heard of these professions, and it was quite a surprise for me, because I was actually at one of the presentations at IIM, and I was actually listening to some of these professions, and I was intrigued and enthusiastic to listen to each one of on what do they do. So it was so interesting that the drone runner is a guy who's actually been is an engineer who's actually handling the drone all the time. He's actually a gentleman with a qualification as that good as that of a pilot. Now imagine a pilot sitting like an engineer but just handling a drone. At the same time, a medical clown is a gentleman I met who's a professional medical clown. He goes hospital to hospital to entertain doctors and patients together, because he feels that life has become too boring in hospitals and doctors have become too serious. So he goes actually entertaining patients several times, because he finds that the doctor can actually get the frown on the patient. A chief belief officer, a person who actually looks at an organization to understand how can he bring the philosophy of an organization together, so that the sweeper and the chairman or the head of the organization have the same vision. A chief dreamer is a guy who looks at how does he make his employers, teams, and his staff dream better, and look at how does he make them into a reality. Epigenetic counselors have a wide range of counseling patterns, including mind body medicine, soul medicine, including looking at diet factors, mind factors, and IQ, EQ, SQ factors. Ethical hackers have been talking about looking at how can we look at data hacking in an ethical manner to actually look at impacts. So there is a need to shift this entire thing from a bedside to bench medicine, and that's why I have structured a program called the Surgeon Scientist Program or the Clinical Scientist Program, which actually talks about how can clinicians get into the scientific arena. And in this particular aspect, I wanted to emphasize to you that I am doing this because a decade and a half more back, I was inspired into learning on this by my teachers who taught me, saying that look, if you do not do this 15, 20 years back, you would miss out on what you're doing today. And today I must tell you, sitting as the chairman of the ethics board for ITBT ministry on genomics, on areas of proteomics, on areas of immunology, on areas of looking at bridging programs such as mathematical oncology, I am fascinated because I'm actually doing this because somebody 2 decades back influenced me and said, please look at this area because 20 years from now you're going to be requiring to do this, and today I'm actually doing this. So while I'm actually a full-fledged clinician, I'm actually spending about 10% of my time on laboratory work, on genetic sciences, on futuristic sciences, what we call the synthetic biology. And my friends, synthetic biology is going to become a most essential part of the program. I was talking to my deputy chief minister 2 weeks back, and he was telling me he's looking at a funding of about 600 odd crores to look at how can he set up a state of the art synthetic biology program for the future. We are currently working with Emory University in Atlanta to look at how do we create a program for the future for synthetic biology, wherein we're going to make our own cells adopt new functions based on information that we have that it can do but it doesn't do. I mean, isn't that interesting that we are going to train a T cell to look at actually specific antigen targeting based on MHC typing, which is a program that it knows but it has not learned because it needs training. So in synthetic biology labs, one of them which is our own at HCG, we train cells to actually perform a new function. So the future of medicine would be genomics, proteomics, metabolomics, and gene side medicine. In fact, I've missed a very beautiful picture of Paul Davis. Paul Davis yeah, is one of the very interesting people. A few years back, Paul Davis was on the cover page of the Nature magazine. And I don't know if any one of you all have heard about Paul Davis. Somebody worth reading about or reading and listening to his videos. Paul Davis is currently working on the role of physics in cancer. And you know the NIH has not the NIH. Sorry, the yeah, I think the NIH has funded him with a very big grant. Yeah, NIH has funded him with a very big grant on understanding, because they felt that biologists have fooled the world for too long on cancer. So they're looking at, can physics answer the question? And I must tell you, last month I published a paper on this, which was published in one of the Elsevier publications on the role of carcinogenesis as electron acceptors. It actually talks about organic chemistry, and quantum physics has nothing to do with biology. It talks about looking at quantum tunneling, quantum entanglement, and other phenomena. Now, why did I write this paper? Because I also believe that physics and chemistry, including quantum physics, can play a very important role in biology. Biology has its basis in chemistry, which has its foundation in physics, which forms its basis on quantum physics and mathematics. This is science is interconnected, but we've segregated it based on various departments. You know, a very interesting thing that came. I'm specifically talking on cancer, but this is quite generic. So there was a blue ribbon panel that was actually set up by the Lancet Oncology Commission and the government of US, the United States, funded by NIH, to look at what are the top priorities for the future of cancer. What can we do? Like, I mean, imagine if the world's best researchers were to imagine that this is what I want to actually fund cancer research. How could we fund them? How could we support them? So they actually came up with a brilliant set of recommendations. It's a beautiful paper in the Lancet. It's quite a large, elaborate paper which talks on 10 recommendations, which are these, but I'm not going to go into the depths of these things. What I wanted to tell you was, this was called the Cancer Moonshot, and he talked about 5 important things. The 5 important messages from the 10 recommendations was enable technologies, look at immune systems, look at precision medicine, personalized medicine, and big data. My friends, all of these need research. They all need research. Now, the question is that this is a dying breed because there is increasing pessimism about their ability to pursue research and concurrently with clinical duty. So, when I talk to my fellows, when I talk to my, they say, sir, is it possible that we are going to be able to do this kind of a research? I'm talking about my own learning. When I talk to my fellow students and when I ask them, are you able to do research? And there was initial skepticism, but today I must tell you, forget about the routine days. The last 6 months of pandemic period, they have published close to 25 papers. 25. I mean, I think that's on the lower limit considering the, but 25 papers they published during the 6 month pandemic period. And I'm glad and proud today to tell you that many of them or all of them have taken the path of research. In fact, Elseviers honored one of our fellows with a special certificate that he had the highest number of publications in that year, which required the editorial to acknowledge his efforts and write to him saying that he has achieved a special mark among fellows. So the wrong assumptions here are that there is no financial gains. No, that's not true. You have in fact more grants and financial support in these areas if you pursue it in the right direction. It compromises patient outcomes. I think absolutely wrong. In fact, it increases patient outcome, it improves patient outcome. Patient appreciate and look at clinical scientists. They understand that these are the guys who are not very commercial. These are the guys who are not here to exploit you. These are the guys who are believing in science. It's very time consuming. I think it's not, it's a team effort. It's not time consuming. We are currently having 27 such research projects right now ongoing. And I'll be happy to share my Trello board with you to show how do we manage this research. Now it's not relevant to me. I think it's relevant to everybody. If you are a medicine, if you are in the area of medicine, if you are dealing with patient outcomes, I think you need to know that it is relevant to you. So we've just started the
Conference,
surgeon
online
scientist program some
conference.
time back. And what I would want to inspire all of you is that there are 4 areas where you can actually pursue research: basic science, clinical epidemiology, or healthcare research methodologies, in medical education, administration, or healthcare services also, and biotechnology and innovation. Now, why I'm saying this is, I've told my medical social workers, I've been telling my nurses, why don't you pursue a PhD? So we've recently started 3 PhD programs, and we've also collaborated with NHS recently to talk about how we can jointly work on looking at some collaborative work for which we are talking with the London School of Medicine to start a joint PhD program. Now, there are various ways to fund. It can be intramural, it can be institutional, it can be governments, consortiums, through collaborations, through crowdfunding. Today, a whole lot of research has come through intramural NGOs and startups. So, there's a whole lot of areas where we are able to open up funding, where we are able to open up this. And very important aspects I would especially influence youngsters is I've been talking to, some time back, this is in May. Our Vice Chancellor of the Rajiv Gandhi Health University was very gracious enough to call us for a meeting and say, during this Silver Jubilee program, what do you all think can we actually do? And we told them, sir, why don't we actually ask our students if they want to become entrepreneurs? And this is what we wanted to open up on the area of clinical scientists. And he said, would it be enough? And I'm talking about May 25th. When he asked us this question, we said, sir, I think we should give them a chance. And he said, do you think they will actually be interested? And we said, sir, why don't we give it a try? He was gracious enough, Dr. Sachidanand was gracious enough to tell us, go and give it a shot. And I remember the emphatic lines. He said, my name is Dr. S. Sachidanand. The word S means yes all the time. For any good thing, go ahead and try it. So we actually did this. We had 5 days. We brought Microsoft together. We brought Indian Institute of Science. We brought the Rajiv Gandhi University of Health Sciences, the ITBT Ministry Government of Karnataka, Bangalore Bioinnovation Center, IIM, all came together within a span of 2 days and put out a small note saying we want you to come up with an ideathon to look at how can we make a medical hack happen. And they came together and we hosted this program, and we had close to 1,200 applications. This is in a span of 5 days that we did this announcement, and we had 1,200 applications. And I must tell you, of which 200 of them got shortlisted, and of which 27 were the finalists were brilliant. I mean, these, my friends, were first year students sitting in some dissection hall giving me a proposal saying about how they can look at artificial intelligence algorithms and create these kind of convoluted systems which could actually look at environmental factors interacting with human biological factors and creating an algorithm model for treatment directions. There were interns who came and told me that they are looking at educational programs and they plan to quit medicine and they would want to go into the area of rural education for rural areas and look at healthcare related education. I mean, this was just brilliant for me to understand how they bridged research and innovation and brought together a career front. It is possible, and I'm talking not theory, I'm talking practical examples that I learned from the university. I remember June 5th was the program, and our honorable prime minister also came on board to inaugurate and welcome this program in a very, very nice and humble way. I'm going to skip this, but we run this program with nature on scientific writing and publishing, and it's a 11-hour program where we interact with 36 of the nature editors. And I must tell you, one of the most brilliant programs that I've attended. I've made this course myself. It's a certified course which has got almost 30 of 11 hours which you can take online. So we are going to restart this course, and as and when we do it, I'm going to share that information with Akilesh. If anybody is interested, please feel free to join in and participate in this program. It's a hell of a lot of learning on research and innovations and scientific publishing. So that brings me to the last part, and I'm not going to bore you more than this. What I always say is that research is intermingled and deeply associated with innovation. And that is why it is very, very essential for you to understand and look at the link. And it is only through the nurturing of this research that brilliant ideas come out for innovations. So it's very, very crucial for you to embark on a research career and understand, and that could be your game changer. So the European Union and the US groups have come up with something called ethical, legal, and social aspects or implications for research, which they came up with a group called RRI, which was recently emphasized in the European Union meetings also, where they said about responsible research with innovations is going to be the hallmark of the 21st century. I don't know if I missed out on something here, but there's going to be a very crucial bridge between research and innovation, between academia and industry, which is going to drive home the philosophy of what I would call a kind of a bridge program for research and innovations together. And this is what I call the research innovation new age. I was talking at the United Nations program about 1.5, 2 months back, where I actually spoke about something called conscious capitalism, where we actually create wealth with value, where we look at ambition but also look at purpose, and that's where we look at research combining with innovation. And that's the fusion I was talking about here, and why it is important to have ambition and purpose together to define the path to fail successfully. And on a philosophical note, I want to end with saying that the goal of education is knowledge, and the goal of knowledge should be service. So remember, research, innovations, education, knowledge all finally need to end into service. It should be useful for another fellow human being. It should be able to help another human being, and that is why it is going to form the basis of a lot of our philosophies. And the most important thing in research is the freedom to fail. Many of the times we say that every time we do a research project, we say that the research may not be useful. More than 90% of the research fails. So I just want to leave you with two important examples. The first one was that in a Welsh hamlet in England, there was a clinical trial that was going on by Pfizer on a cardiac drug, and the clinical trial had failed. They did not succeed this clinical trial. So the company asked the clinical team, the clinical research team, to go back and withdraw the tablets from the people who had actually been given these medication, because the medication was not successful. So when they went in and when they gave the medications, when they went in to take back the medication from the patients, the patients refused to give the medication back. And this was something that was very unusual for the clinical research team, because they had actually gone to tell them that, look, the research is a failure. Please give us the medicine back because it is of no use. but the patients refused to give back the medicine. They said, no, we don't want to give the medicine back. And this was a very strange observation. When they went back and they gave this information back to Pfizer company, the Pfizer company did further research on why did they not want to give the medicine back. And that is when Viagra was born. So Viagra was a result of a failed project. And my friends, all of you know today, it is one of the most potent infertility drugs, that is the highest seller in the market. So that was a product that came out of a failed project. You look at this particular interesting story. This is of a scientist, a biologist who was intensely working on looking at microbial colonies and looking at how he can contain them. When his wife asked him to take a break, when his wife asked him to take a holiday, naturally he had to follow his wife's instructions. So he took the holiday. What came out of it was that when he returned from the holiday, he had left the petri dishes in the waste in the basin without washing them, and a lot of areas wherein he had left it there had not grown these molds, and that led to the discovery of penicillin by Alexander Fleming. So what happened later was his wife got him a maid to clean those areas of the basins, and he discovered the penicillin. Very, very important. What I wanted to reiterate to you is why it is important to have the freedom to fail. Not every research, every innovation is going to give you a massive success, a Nobel Prize, but these failures are going to be the foundation stones of the next aspect of your ongoing work. And that's why I always say that in medicine it's well acknowledged that we are all dwarfs standing on the shoulders of giants. So we run a small innovation program called Maker's Nest also, where we actually encourage people to come share ideas, look at cross innovations, build systems, and helping youngsters in the path to innovations and entrepreneurship also in this. I'll be happy to guide anybody in this regard. And I think with that, I'll close my presentation. I again want to thank your entire team and wish you a very hearty congratulations to Dr. Akilesh and the JIPMER team for taking up such an unusual topic and allowing all of us to speak our mind out on such unusual topics. Again, thank you, Karthi, and the entire organizing team of JIPMER, who have pulled this program off in such a beautiful manner. If you have any questions, I'll be open to answer them.
Hello. Yeah.
Thank you.
Yes, sir. Thank you for that wonderful talk, sir. It was entertaining and with a fair bit of anecdotes. So I got a question on email in this regard. One thing was you had mentioned a lot of aspects for youngsters. Okay, the question on the screen is not the question that I'm talking about. This was another question which I got it in email. One thing was about what do you think? I mean, youngsters, I do believe that, people who are entering into the stream as, youngsters, young professionals, they need to be encouraged. But what is your aspect on people who would like to start a bit late? Do you have any pointers for them? That would be the first question, sir. So,
I
maybe.
must tell you, there's nothing called starting late in this, because even now at many places I'm starting. So I must tell you, last month I was sitting on microbiome projects, something which was very fascinating for us. A couple of weeks back, we were looking at complete new restructuring on synthetic biological related aspects, on CRISPR, other technology, completely new to us. Now, this ignites the child in all of us. I mean, I must tell you, you have to maintain the curiosity of a child when you look at research. And that is when there is no bar, no particular thing of early and late. Everything seems to be at the most optimal time. It makes you feel younger, makes you feel more richer, and improves your productivity. You can add a few hours to your day when you do research.
That's true, sir. Dr. Vaishali, would you like to have a few more questions to the speaker? Dr. Vaishali has anyway put up a question. How can I join the PhD program started by HCQ?
I think what I'm going to share with her is about how to apply for these PhD programs. We have some applications coming up. It's through the university, so which is the state government university. So I'm going to share, because this month we're going to be structuring all the PhD program which is with the university, which is with the deemed university, which is separate from the government university, and some things with the universities like London, Netherlands, and others. So we're going to share with you a detailed program. Hopefully soon, I'll share that Akilesh with you. You can share it in the groups and talk to more people about this.
So definitely, sir, I would do that. Whatever material is shared with me, and in fact, I would also like to say that if people have any more questions on the sessions, even after the session is over, feel free to email. We will try to get back to the speakers, and within a week or so, we'll try to get back with you with those replies as well. So please feel free to keep asking. You do not have to restrict yourself only to the live sessions. And so there is the other question which is there on the screen. What would you like to give? What advice would you give a health professional who is new to evidence implementation, or in our case, pertinent to our topic, I would say, who is new to even research field as per se. A lot of people are interested, but then they are lost as to how would they want to proceed, and any specific pointers would you want to give? Something like key
I
points.
Correct. I think you know what, this is something which I faced also when I entered. When I actually started this journey, I kept looking at, because it's not just about you need a good research question, you need a mentor, you need an environment and an institution. It's like the viral story of the host, the vector, and the environment. You need all the three in research. Now, it's essential that all the three come together. So, the first thing that the person needs to look at is, do I have a question ready? Now, if you have a burning question ready, but you don't have a mentor or an institution, you need to start looking at, based on the question, whom can you collaborate with? Are they organizations? And I must tell you all, take a plunge and just start writing to those people whom you feel in this area have interest. This is very, very crucial. I used to do this. I used to write to random people. I used to write to people whom I believed were core researchers in this area, and I used to get wonderful encouraging responses from people whom I never thought would respond. And that for me was crucial. So many times, I would write to Sudha Murthy. I would write directly to her, and I would get surprised with within 4 hours she responds saying, Vishal, I think this research area is something which we would be considering to look. The question is to reach out. Do not hesitate to think that he is big, I am small. How should I write to him? Just pick up the thing and write to him, either on your email or a Facebook, or I don't know. There are so many social media. Reach out to people, pursue your research and ask them for guidance. Because remember, these are people who have, if he has been doing something relevant, means he has failed a lot. I must tell you, I must have had the highest number of failures, and that's the mantra, that if you want to double your success rate, you need to triple your failure rate. So you need to go all out in one leg and reach out to people, request them, ask them for guidance, and say, "What do you think I should do? I have this project in mind. I'm interested in it. Would you like to guide me? What are the ways in which I can do? My institution doesn't support research currently. Can I write to you and can I ask you to be my guide in this area?" I mean, these are things that you need to pursue aggressively, and that's my single message to all of them. Your individual question and interest, you look at the mentor who can might guide you, and an institution that can support you. That is the triangle that is required to pull off a good project.
That's a nice reply, sir. This was a question which was part of the Twitter chat by JBI, with due credit to them. And I'd even asked them that, I would like to share some of the responses which were there. Like, Craig has says that someone whose first implementation project failed. So, it so happens that sometimes we do fail, sometimes we do succeed. But the idea is to make an effort. And I also have a thing to add regarding what Dr. Vishal said. When I reached out to him, it was just like what he said. It was a random message that I sent over to him, and right now he's here, collaborating with us, joining us on this talk, and sharing his views. So it is due to these random conversations is how we actually start out. For people with similar interest, common interest on the same ground in the same audience. There is also a person from the software engineering field. Totally, I would say, we would be wondering how is healthcare related to that, but there are people from technical background who also joined, and I met this person during one of the sessions in software and healthcare related conferences. So I do believe a cross domain collaboration is a key. We need to really learn from other domains as well, not just specialities. So coming over to the other responses, I would definitely share most of these, screenshots and other materials which are collected. So the other aspect here by Daniel is build relationship in the organization where you are implementing. So I think even though this Twitter chat is about implementation, it gels well with even the concept of research. Research implementation are kind of quite well related, and it's not the end result. Research is not the end result. It is only when it is implemented that the research becomes useful. So in this aspect, there were a lot of innovative ideas and thoughts which had come up. And Dr. Vaishali had also made a comment in the chat box earlier that she was not happy about the status of research per se. And that was one of the reasons why she felt there is a definitive need for better quality research in India, and as well as in the whole world per se. That's the reality there, that most of the research is not actually finding use because it is not policy driven. It is not based on the requirement of the end user, like you mentioned earlier. That's an excellent point there again, that the research should definitely be useful for the end user. So that is it. And anyone else have any other questions? We do have another, nearly 5 minutes before we can start with the next session. Our next speaker is already there in the audience. But if anyone else, any other questions or any other remarks in the same topic, please go ahead. Okay, fine. So, yes, just as a closing remark, we had a discussion with Dr. Vishal Rao. He succinctly pointed out the importance of research and how we could pursue. And I would take my key takeaway point in his whole aspect is about, I was really impressed with the cross-cutting themes. It's not about just one area or one field that we need to be talking about. We need to really reach out to people from other streams as well. And interestingly, we have people from different domains in the audience, people from software, people from clinical epidemiology, dentists, medical specialists. We also have people who are clinicians working in the CHCs and PHCs. So I think, with this cross-cutting domain of people here, we need to really look into what we are planning on, and how we could collaborate for a better and a useful research. So with that, okay, there is another one comment. The patients from rural area of oral cancer are more than urban, and they never get proper treatment. Can Dr. Vishal comment on that? Dr. Vishal?
Yeah, so this is again a very relevant question. See, so what I did was I have been working with a group which has been looking at artificial intelligence systems for detecting mouth cancers using simple mobile cameras. But the point here is, I think the most important landmark paper in Lancet came out from Dr. Shankar Narayanan's group, which made a very significant dent here, showing about how simple healthcare workers can make a difference by picking up cancers early. Not doctors, not nurses, simple healthcare workers, and all we need to do is open our mouth. So there are simple ways to implement this. I've been working with the Karnataka government on the oral health policy, looking at how we can work on this in an effective way. So there are many such simple things that can be done in a robust fashion to make a difference. There is science. So I'm telling, for the question she asked, there is a beautiful research that shows that you don't need fancy technologies. You do not need a great amount of expenditure. You need to open your mouth, and a healthcare worker needs to examine you, and that could bring down mortality. Imagine what a simple thing that Shankar Narayanan showed through that research of a cluster randomized control trial in 2005. So now, can we translate that particular, like Akilesh said, can we translate that research into a policy and then into an effort, is what we need to work on. So we've been working on this thing of looking at a simple AI camera that can be used by healthcare workers or by patients themselves in rural areas, and lead to more effective screening, wherein we create hundreds of healthcare workers, reduce their work. And that is what technology does: simplify and reduce your work. and improve outcomes.
Um, yes, sir. Sir, that's well put. There is one more question from Dr. Ram Mishra. Along with working in corporate, how can one be involved in research? Along with working in corporate, how can be one involved in research?
Sir, I am one classical example, sir. I am working in a corporate sector and I am working on academic programs. So I am in charge of academics, and at least I'm telling you, within my department alone, I have about 27 projects running. And I have a fellowship program, I have a training program, plus I have the Royal College of Surgeons affiliated fellowship program, and we are starting PhDs. So it is very much possible, and in fact, I feel that it improves productivity because now my team has expanded to almost about 13 people. This is excluding researchers. Just that. So it is, in fact, a real ideal situation for us to pursue academia and research in a corporate setting because it gives a lot of meaning. Otherwise, we would only restrict corporate to the aspects of the economic side of it. So when you add the academia, you give a balance between industry and academia, and actually, as doctors, for us at the medical fraternity, it becomes a good relaxation also. So I always say that research can be therapeutic, academia can be entertaining, and it can actually give you a break from just the routine rut of running behind this. So that's the kind of new models we will need to create in the future, as what Harvard does, and MD Anderson does, a Memorial does, or a Stanford does. This is possible, and we need to incorporate that well into India in both ways.
Thank you, sir. I think that would be bringing us to the end of this particular session. The questions can be, you do not have to stop your questions. We would like to curate the questions and send it over to the speakers. So please do keep coming up with the questions or email us the questions so that we can curate them, send it to the speakers, get their feedback, and all of these interactions will also be shared with you after within say 4 or 5 days after the session is over. So it was a very nice session, and I'm really happy about people really coming up with interesting questions to the speakers. So I would like to just take it over to the next session right now. And before we go on, I would like to thank Dr. Vishal for really joining in and giving his expert views and insights. I
Thank you,
will be
thank
very
you,
happy. Yes, sir.
thank you so much. Thank you for the opportunity.
Yes, sir. So we are really grateful that you could share some insights in this regard, and it would be nice if you could stay along as much as possible, and also give in your inputs wherever possible. We have the session that
Sure.
will be going on till 3 p.m. with a break in between. Thank you, sir.
Thank you.
Yes, sir. So with that, we have our second speaker in tow, Dr. Manish Kumar. So Dr. Manish Kumar is a former colleague of mine, a senior colleague of mine from AIMS Gorakhpur. So we were having, a similar discussion. Again, I would say that, it was all a last minute decision around 4 or 5 days ago. I believe it was Wednesday when I messaged him. Actually, it's an excellent thing again. I had messaged him and, their department head regarding, this session, and Dr. Mahima Mittal. So she graciously said, I have a person who's the right person for this job, for this whole session. He's passionate about the whole concept of evidence generation and impact and everything. So we have Dr. Manish Kumar who is joining us. He's associate professor in Department of Pediatrics, AIMS Gorakhpur, and he's also the member of curriculum committee and medical education unit in AIMS Gorakhpur. Uh, Sir, I think I would, with this short introduction, I would, like you to take over. He's very passionate, with a childlike curiosity on this whole topic of evidence-based medicine. Even yesterday evening, we were having, quite a discussion there. So, I think that it's really fitting that, you're joining us at this moment. I would like to hand it over to you, sir.
Yeah, thank you, Dr. Akilesh. Very kind words. And I bring greetings from the banks of Rapti. Now, the presentation that I'll be giving after Dr. Vishal Rao's, enabling performance, where he talked about so many enablers related to research, I'm almost apologetic when I say that I'll be talking about easier said than done. Uh, right, so is my screen visible?
Yes, sir, it's visible.
Yeah. So yes, I'm almost apologetic when I say that there are barriers to evidence-based healthcare, and the typical phrase that you'll hear from us clinicians is that it's easier said than done. Uh, Now, regarding my expertise, well, I in fact bring my own experiences of overcoming few of these barriers, being a very late bloomer in the field of evidence. And if any of you who are in this virtual platform thought that the word experience in a talk about evidence is a little bit of an irony, then I think we are at the right place to set the ball rolling. So the objectives of my talk will be why do we clinicians consider it a pipe dream? Few people call it an ivory concept. So is it just about our attitude towards evidence, our capabilities regarding handling evidence? Or is there something in the whole movement of evidence-based healthcare that needs to be looked at, that needs to evolve? And then finally, the utopia of evidence, how can we bring it to the clinical dystopia? We are living in a dystopia right now with COVID around. So these are going to be the three main headers under which I'll be taking this session through. So the opposition to the whole movement of evidence-based medicine actually started right from its inception. So this is a 1995 Lancet editorial where they said, we deplore attempts to foist evidence-based medicine on the profession as a discipline. And even 2 decades later, people still thought that the whole movement of evidence-based healthcare is broken and evidence-based medicine is broken. Now, why is that? The initial, knee-jerk reaction to all this criticism was that yes, there are a few limitations, but most of it is the misperception of perception of clinicians when they talk about evidence. Now, I will not be that singular. I believe in plurality, and therefore I will say that those perceptions and the inherent limitations that the whole evidence gamut brings up to the table forms a few barriers, and we need to look at those barriers very carefully. And no better day than today when we are having the inaugural evidence-based World Healthcare Day. Now, before I move any forward, so this is about a story of a grandpa with gray hair who had this feature phone and was
Um, Dr. Manish, we lost your audio. Just stay online, people. I think there is a small internet outage there. Dr. Manish, we can't hear you. We can see the video feed, but we are not able to hear you. Are you able to hear us? Are you able to interact? Maybe you have to, disconnect and rejoin perhaps. Dr. Manish, you may need to disconnect and rejoin. And
Is
yes,
this,
sir. Yes, 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 yes.
am I back? Okay.
Yes, yes, you're back.
All right. So I don't know what happened there.
So we lost you at the story when you were starting with the grandpa story.
Okay. Okay. All right. So, all right. So I was talking about grandpa, and now grandpa got a new phone from his grandson, for video calling. But he was not able to place those video calls, and he found the phone, of not much use because it just wasn't suiting his style. Now, when the reluctance from grandpa came regarding the use of the new smartphone, the grandson thought that the problem is with grandpa, his capability to use the phone.
So you froze again.
Uh, am I
Yeah,
audible?
you're back now.
All right. I'm sorry for these vagaries of the internet, but am I audible now?
Yes, sir, you're audible.
All right. Sorry. So the phone is evidence. I was talking about a new smartphone for an older generation guy who's not able to use it. So for my analogy, the phone is the evidence, and we clinicians are those grandpa not able to use the evidence the way it's meant to. So the problem actually lies with both of us. The way evidence based healthcare is being formulated, and the way we are using it. Now, let's start with the attitude of clinicians. And this is typically what happens. We have knowledge, we have an attitude towards a particular thing, and a combination of all this turns out into behavior. And it's this process that Cabana et al. Used when they said, looked at why physicians don't follow clinical practice guidelines. And they said the problem lies with the knowledge aspect as well as the attitude aspect, and all that means that there is absolute non-adherence to the guidelines as far as behavior is concerned. So what is the problem with knowledge? The first thing is the accessibility to evidence. Now, not everything is full text. You don't get access to all the various databases. And then even if you have access, what you'll end up with is actually a lot of information, too much information at times. And within those too much information, there is contradictory evidence. And all that leaves a clinician flabbergasted. Then comes the more important element of attitude. And then there are issues of non-agreement. This non-agreement can be very general one. I don't believe in this evidence-based healthcare, or it can be specific one where you look at a particular guideline and say this I don't agree. Add to it the outcome expectancy of us clinicians, where they think that with this evidence the outcome won't be great, and this is very unique to each clinician. The issue can also be of self-doubt, where we think, I don't know if I'll be able to implement it in my practice. And sometimes, that self-doubt makes us a non-starter as far as implementation of evidence is concerned. And finally, and perhaps most importantly, the comfort zone, the inertia of usual practice. You don't want to get out of that comfort zone. And this one is interesting, heuristics, which basically means you have a shortcut to a problem, and it sort of works well, even if it's not the best option. And to this end, there is a book by a person called Daniel Kammer, who won the economics Nobel Prize. And he writes in his book, Thinking Fast and Slow, that there are two systems of thinking. System one is very intuitive, very reflex. And system two is a little structured, where you break down the problem, look at it very analytically. And it's been seen through research that it's actually system one which comes to foray, given an option, where we jump to certain conclusions. We like to make clinical decisions where it's sort of easy to make. We don't want too much complexity into it. So that attitude also, becomes an impediment with the evidence that we have right now. Now, resources. Time is a resource, and this particular, correspondence that published in Lancet, where that particular group, did an emergency call, and in that emergency call, they attended to 18 patients, which had a cumulative, 44 diagnoses. And when they found out that if you looked at just the nice guidelines, they would have to spend 122 hours, to keep themselves abreast of the guidelines. So the too much evidence means it'll be short on time. And scenarios like ours in India, like in Gorakhpur, this time is a very important resource that we don't have when we think of evidence. There are issues with finances, access to the information. Then there is, the whole gamut of insurances where a particular set of, intervention, which might be very useful in terms of evidence, is not open to remuneration. So that is an impediment. And finally, there are organizational constraints. So you want something to be implemented in the organization, but constraint in terms of policies and constraint in terms of finances don't allow you to practice evidence-based healthcare. Now, this is an old study. It comes from Netherlands way back, 20. It was into the year of 2000, and they again looked at the barriers, and their interpretation was very similar. There are cognitive factors such as, nobody will ever read a guideline. About 1/3 of them have very insufficient evidence base and have lack of knowledge regarding all that goes with evidence. About half of them don't have enough of an attitude to practice the evidence-based medicine. And nothing has changed in the next 1.5 decades. If you look at this article, which comes from China, and they look at all types of healthcare workers, from physicians to nurses to technicians, and they think that in terms of resources, in terms of time, in terms of knowledge and training, there are barriers which needs to be taken out as the top barriers. So this was regarding why clinicians, attitude and behavior is an impediment. But is there something wrong with evidence? And well, the storm was gathering right from 90s, where the talk about pitfalls became more prominent than promises of evidence-based medicine. The good got clubbed with bad and ugly of evidence-based medicine, and it was being evaluated from all sort of angles, even philosophical ones, and even evidence-based insiders. They agreed that the movement was in crisis. So, what are the aspects to this whole, gamut of evidence-based medicine, which becomes an impediment when it comes to implementation? Now, there is a tendency to evidence becoming, a cookbook, a straitjacket, because many times its implementation is very template driven, and there is this very obvious, bad aspect to it is that it denigrates clinical expertise. Now, you may say that with the new definition of evidence-based medicine, they say it inculcates clinical expertise, but still the way it is being implemented is very template driven, and people are afraid that any deviation from this template will be a folly on their part. And it makes the whole art of medicine very technocratic. And this aspect of evidence is sometimes, what keeps people away. Then there are concerns regarding the evidence movement ignoring patient values. Now, again, I'll say that the definition itself has that, it will inculcate patient values. But look at the evidence that we are collating. The research that is being collated as an evidence has minimal patient output. And if somebody does research on patient experiences, then it just is considered in a lower hierarchy of evidence. The RCT is the thing. So if you're talking about patient experiences, it will be devalued to a lower hierarchy. And then there are power imbalances. Sitting in this particular room of my consultation chamber, I will think of what my patients would like me to research on. So as I said, there is minimal patient input, and the emphasis only is on those who are seeking healthcare. What about those, in their homes? What about public health? So these patient values, many are agreeing, is being lost in the translation of evidence. And then the biggest blot that the whole evidence-based medicine got, and it was in terms of distortions in favor of some vested interests. So as Mark Twain said, that there are three kinds of lies. There are lies, there are damn lies, and then there is statistics. And this is what was highlighted in this book called Bad Pharma. So statistical significance is equated to clinical significance. And is that a good thing? The answer is no. Then we are not interested in patient-oriented outcomes. We're talking about surrogate outcomes. And anything which is not supporting a particular theory never gets published. So there's publication bias. All those distortions is not leading the evidence-based medicine the way they should. And then there is this famous adage that you read the textbooks, the diseases they don't. So they are a poor fit. We don't have clean, clear one morbidity cases. Generally, patient comes with morbidity, and hence evidence-based medicine in its characteristics of linear causality, where there is an effect which is produced by a particular thing. So this is a linear causality. It doesn't work that way most of the times when you're talking about multimorbidity. And then EBM tries to break down each aspect of the problems and then looks at it individually. It's very disjunctive, where the holistic picture sometimes gets lost. And this is a case in geriatrics. If you look at any discipline for that matter, where there is a combination of morbidity, the evidence is not that easy to implement. And then obviously the over-reliance on randomized controlled trials. So whenever we talk about evidence, we talk of PICO interventions. But is that all to research? The answer is, well, most of the research that we have available to collate is actually not RCT. And the moment COVID hit, we knew that there is a nemesis to the evidence-based medicine right there, because our knowledge gaps had questions such as, those who died at home, were their deaths avoidable? Why did the PP supply chain broke down? Why did the health system, how will the health system resilience play out in this pandemic? And it's not easy to make a PICO out of it, right? So the over-reliance on RCT is not helping us, get the evidence when it's needed, especially in a case of emergency where things are not as, compartmentalized as sometimes evidence tries to make it into. And everything that is being pooled into the evidence funnel, the research. And I was really, amazed with the enthusiasm Dr. Vishal was talking about how the research should be. Because at this point of time, the research is not following that. Our questions are of low priority, and the research designs are inadequate with lots of biases. And if you're doing something of an evaluative research, the kind of research that Dr. Vishal was talking about, well, the evidence ladder will give it a disincentive, put it a little lower down. And then whatever research is being done, whether all of it is being published, whether we can access all of that, well, the answer is no. And finally, whatever is being published, you want to do a systematic review. Because of improper reporting, sometimes they are not usable. So all that means that the research is getting wasted, and we are not able to generate the evidence that we set out to do. So the last part of it all, how do we get a grip? How do we get research into practice? And for that, I'll look at the behavior change wheel. This was suggested by Suzanne Michi. And what she said that a behavior is sort of decided by three components. There is this inner wheel, the inner green wheel, which is the source of our behavior, and it depends on our own capabilities, the opportunities that we get, and what is our internal motivation, right? And then there is this extreme outermost wheel, which is regarding the policies, the guidelines, the planning, marketing, legislation. So the external enablers, and within these two circles are all the interventions that you should do to change your behavior. And this can be in terms of education, training, coercion, providing enablers, etc. This is an important concept to understand, because if we are talking about how we can break down these barriers in terms of our own attitude and in terms of everything that's wrong with evidence, we have to hit our intentions using these principles. So almost using similar principles, and de Grauw et al., they talked about of a sequential approach, where the first thing that we should do is orient. So I don't know, there might be a person who has a brief idea regarding evidence-based healthcare, right? So the first thing that we can do is orient them, promote awareness, stimulate interest. So if he or she is an absolute novice, this particular event might be that little stimulus that is required. And those who are already oriented, well, the idea is to bring insight to them. They need to understand that their usual routines need to be altered a little, and they need to understand why this is important. And herein comes the role where the packaging of evidence becomes very important, right? So if you're talking about a 300-page evidence document, nobody's going to read that. If you're talking about a 3-page executive summary, well, some of us will, definitely. If we talk about infographics, most of the public is going to look at it, right? You need to package your evidence well so that you're able to create insight and people understand the whole movement of evidence-based healthcare. And along with it, you have to have simple audits where our day-to-day clinical activity is being audited. So the idea is to implement there where the rubber meets the road, right? Right in the rounds, the insight, the training should be so formulated that insight starts developing very early on. And once that insight is there, with sustained focus, acceptance will come in. And to bring that acceptance, what we need to do is to highlight examples where evidence is being implemented to the benefit of society. We also need to ask our stakeholders, and this has to be a very, very local exercise regarding their problems with implementing evidence. And again, there is no cookbook. You will have to deviate one way or the other locally to bring in this acceptance. Once the acceptance is there, time for change. And here you require leaders, your organizational leaders who put in place all the resources that we talked about. When you try to change practice, you would require those resources. So once the change is there, the biggest challenge is regarding maintenance. And this maintenance is a twofold thing, both the inner circle of the behavior change wheel and the outer circle of the behavior change wheel. It has to be embedded, the routine of evidence implementation, not just in personal routines, in the unit's routine, but also in the organizational practices. So the legislation, the policies, the funding has to be that way, right? So I find this a good template how we can implement evidence despite all those barriers. And it's not just about our implementation. The evidence has to evolve. So there is a call for evidence 2.0, which is very patient oriented. All our research questions should be patient oriented, related to patient oriented outcomes, and there should be that foothold for expertise and judgment. That flexibility. Evidence need not be dogmatic. Then it should be easy to understand. The whole packaging of evidence, uh, uh, the numerical literacy definitely has to come amongst us clinicians, but even then you have to make it easy, almost to a level spoon feed. And the evidence has to be individualized so that you are able to use shared decision making, bringing in patient and family centered care. So there are n number of tools. I find the decision shared making tools that are there on the Mayo Clinic website very informative, where you talk about patient values, what kind of risk is okay with, uh, how he wants his routine to be. Let's say it's about oral hypoglycemics. So if the risk profile, how it will affect his day-to-day schedule, all that comes in those infographics. So the shared decision making becomes very, very important. And finally, perhaps our biggest IT skill is how we can generate evidence which is beyond clinical environments. How we can put it in the public health domain. And COVID has shown us that it's not about RCTs. It's about how you understand your own health systems. So our evidence, our research focus should be that public health system. So putting it all together, the actions to deliver real evidences, as Trisha Greenall says in this BMJ article, is that the evidence has to be of better quality, patient-oriented, and to be presented in a better way. The clinical training should go beyond books, just background knowledge, and we should train in how to search and how to critically appraise, because many of the our perceptions are because of lack of these skills. However hard the pharma industry may try to say that particular thing is good, if you have the critical appraisal tools with you, if you have that skill, you still will be able to see what is good and what is bad for the patient. And then obviously beyond the templates, the clinical judgment part needs to be honed. And finally, the shared decision making skills, where the patient becomes an important aspect to the whole management, needs to be promoted in our clinical training. The policies should be such that they resist any use of evidence for the sake of vested interests. And those are very important ones to bring everyone on board. And finally, regarding publication biases, the demand from publishers should not just be on methodological robustness, but they should look which studies are usable, right? So it's not about just framing the perfect study. The utility of studies needs to be very carefully evaluated. And those who are funders, the emphasis in Evidence 2.0 should be on public health, given the times that we are living in. The research needs to be rethought, and I think the previous session was all about this, right? So just a sort of a re-emphasis on the first session, that the research driving policy is the way we know evidence-based practice right now, where there is an intervention and you do a feasibility in pilot trials, then you do a randomized trial, and then you find evidence and you collate, and that becomes a policy. Now this is research driving policy. What is lacking at this point of time is policy driving research. And the middle part of it all, the evidence which is generated through observational studies, that needs to be looked very, very carefully in this whole movement of evidence-based healthcare, because it can help us, provide with interventions. You can develop interventions based on the evidence that is generated through observational studies, or like we are doing right now in the COVID times, we can develop policies based on the observational evidence that we have. And once you have a policy, it will be set out into action. And once the policy action is there, that needs our evaluation. So we should evaluate, assess, and find whether there is enough evidence to better this policy, right? And or we need to do it altogether in a different fashion. So the practice-based evidence needs to be, sort of promoted, where policy is the driving force as far as research is concerned. And sort of a final word on how evidence needs to evolve. The complexity of a clinical environment asks for complex system paradigm of research, right? So the perspective cannot be just singular, right? As Trisha Greenall proposes in this particular article, that right now our evidence-based medicine practice is having a very singular perspective, which needs to be turned into a multiple perspective, as far as scientific truth, quest for scientific truth is concerned. Our goal for research should be, about generating insight and wisdoms and not just, finding generalized solutions. The model of causality needs to be emergent instead of linear, right? So there are multiple interacting forces and all of them needs to be taken into account, and it might be difficult to give fixed effect sizes to each one of them, but the multiple interactions need to be evaluated properly. Finally, the representation needs to be very plural. You cannot be very authoritative when you are talking about evidence. So I think the way evidence is right now needs to adapt to these complexities, and this complex system paradigm might be a way to look at it, where our analytic focus sort of shifts from A versus B, or influence of X on Y, to dualities, to interrelationships, etc. Now, when we talk of evidence, and the first thing that creeps up beyond medical field, beyond healthcare, is a whodunit, a legal sort of a meaning to evidence, right? So evidence can be in terms of DNA fingerprinting. You have very precise evidence of a whodunit. Um, the crime scene had some DNA and you have fingerprinted and the culprit is there. But many a times, and in fact, uh, perhaps more interestingly, the science of deduction is there, right? So you look at circumstantial evidence, that missing ring, that murder weapon, that glove, etc. And that science of deduction also is equally important when you're looking for a whodunit, right? So as Martini said, that reconciling to the different meanings of the word evidence in evidence-based medicine would help put EBM in its rightful place. And I think we need to be open. We need to move beyond just RCTs to observational studies and how we can collate them together. And more importantly, as evidence is evolving, we also need to look at our own motivations, our own attitudes towards implementation of evidence. And once all that is set in place, perhaps we will have better implementation of evidence. Thank you.
That was well said, sir. And yes, sir, we had some minor hiccup in between, but ultimately it's been a really an amazing presentation. And just give me a minute. I wanted to share the screen regarding one of the questions. Actually, this I would like to put it out to the audience first. This was one of the other question that was coming up with respect to today's morning Twitter chat from with JBI. So the real world or practical implementation. These words get used a lot, but what does practical implementation mean? Is it different depending on the project aims or context? They're just trying to ask is there any difference between the real world or a practical implementation concept when it comes into research or evidence generation and implementation? So, people could put in their comments in the comment box. I would give it a couple of minutes. And here I just wanted to share a few summarizing points, what Sir had actually mentioned. Time and again, one thing he stressed was about the linear causality. That the current evidence generation methods, what we are actually trying to do is something called as a linear causality. Like, X causes Y. Maybe, there is some other pathways where X may be influencing Y, or there may be some other, A, B, C, D, or, any other kind of variables which is actually influencing, or the environment in which X is present may be the reason Y is happening. So these are all the concepts which are stressed in the concept of complexity. I would just like to share a small anecdote regarding the concept of complexity. One beautiful example which is shared for complexity is about you have, as parents, the mother and father, they get a first kid, and they are rearing the first kid with the same environment, same food, same education. Of course, they are the same parents, and they are teaching the same ethos and everything. And after some, 4 or 5 years, they get another kid. So, do you think by the time these kids are all, 9 years or 10 years or 11 years old, each of them, do you think both of them would have the same attitude, would have the same belief, would be having the, would pursue the same interest and everything, in spite of everything being the same? Anyone? You could just put up a yes or no in the chat box, or, does anyone think, they would be same? If anyone thinks they would be same, I would like to hear them. Okay. So the whole, this is the, in simplest terms, this is the concept of complexity, as to, the in spite of the environment being the same, environment is the same, but there are other influences which also influence the total outcome. This is to summarize the concept of complexity. So we have a question. Yes, yes, yes. We have emphatic no and not possible from everybody. Thank you. And there is a question from Dr. Krishnan. Sir, why don't professional organizations in India, such as specialty associations, give their evidence-based guidelines relevant to India instead of clinician having to depend upon Western guidelines for almost all diseases and disorders? Yes, so this brings us to the question of, the whole concept of context-specific thing. And yes, Dr. Derek, welcome. Good morning. Yeah, yeah. Dr. Derek is our next speaker actually, and he has made it. It's early morning for him, and he has made it a point to join us. Thank you, sir. So, meanwhile, Dr. Manish, would you like to take this question? Why don't
Yeah,
profession? Hmm.
absolutely. So I think it's a very important question, and we've faced it a lot because whatever Western guidelines that we get, at times you can question their external validity in our circumstances. Now, why it doesn't happen in India that much? The answer is twofold. One is at the level of the primary research that we are doing. Not enough of it, as I've pointed out, is based to the context, to a particular specialty, the questions which are pertinent, right? So we are not asking enough questions and thereby gathering primary research from our own setups. Second is in terms of the way the specialty association, the professional organizations are looking at the whole evidence-based thing. It is a truth that we haven't done enough, but as far as movements such as these and people like Dr. Akilesh and in a small way us, if we get together, perhaps we'll have more. But at this point of time, the primary research in our own context is lacking with the right kind of questions, and hence we don't have enough evidence to collate them and form guidelines which are specific to India.
I'm sorry. I'm sorry. I'm sorry. I'm sorry. I didn't unmute myself.
Yeah.
Yeah. Okay. So I was telling about this. The Western guidelines are followed by legal system. Yes. The one reason is that what I wanted to highlight is about how Dr. Manish had highlighted about evidence-based policy decisions. The other one was about how policy would be influencing evidence generation. And I think at this point we need the other thing, the latter. That is, policy should be driving some of the research areas. They should be defining the thrust areas, and then based on the situation analysis and based on the data that's available, and that should be presented to the researchers so that they could pick out on guidelines or pick out on areas, the so-called knowledge gap that is there. And that would be the key thing there, to generate evidence based on the policy requirements, based on the community needs, based on the clinician needs as well. I would say the clinician needs, the patient needs, and the community needs are three important aspects which should be driving research. And it should also be that we need people who would be influencing policy. So that's again one thing. And we do have here certain perspectives, like for the question number one, certain perspectives which were shared in the Twitter chat earlier was that from our perspective, practical implementation focuses on actual workflows and impact. It depends on the context and culture. So context and culture is very important when we are interpreting research and adopting it. So in this case, we need to generate context specific and culture specific research. That again becomes a very important aspect. So we need to design research based on the requirements. So that's a good solution that we would need to adopt. Mm, and we also have certain other remarks. I believe evolution of electronic health records will eventually push India to rely on its own high quality healthcare data. That's true, Dr. Ram. Actually, it's a nice point there. Reliance on or the availability of data, electronic health records, electronic information system. But the problem is about how is the technology going to be available in the remote corners. So, any of the speakers, Dr. Derek, Dr. Manish, would you want to answer that about the electronic health records, how it could help us in or help us remove the barriers in research?
Absolutely. I think, the whole electronic health record thing brings us to the debate of big data. And when it comes to questions which are related to public health, this definitely is going to help us. Uh, but the idea is that you need a very robust system out here. What we have right now are pockets of excellences. So there might be a very good electronic health record at JIPMER, which might drive research as far as your institute specific research, but it cannot give us answers to whatever is being done in public health. So electronic health records need to be merged with all sort of demographic variables that we can capture from public, and then the policy decisions will be data driven.
Uh, Derek?
I would agree with that. I mean, electronic health records are quite useful for gathering process data, and it can give us a really good idea of what practitioners are doing. One of the problems we have in Europe, for example, is that GDPR regulations around data sharing make use of electronic health records a bit more challenging. So you really do have to have quite clear research goals and directions for that. But we certainly could make an awful lot more of electronic health data than we currently do. But it's about setting it up and getting over some of the barriers that exist, because quite a lot of the public are quite anxious around about how their data is used. But I think as long as it's clear and we have clear guidelines on how the data is being used and what it's being used for is important as we move forward.
Yes, Thank you, Derek. And even in this Twitter chat that happened today morning with JBI, there were a few resounding concepts. Dr. Manish had mentioned about the modality of dissemination. It is important how you disseminate your evidence findings, the wordings. He was talking about the importance of infographics and summarizing in simpler terms, so that it has a better reach. And these are also very important. And sometimes in a country which is having multiple languages, it may also be relevant for us to use translated evidence summaries where possible, to generate awareness about important evidence is available, especially in a country like India, where we have so many languages being spoken, and where there may be slight differences in the competency with respect to English. So it may, and it also needs to reach the consumers, as much as it needs to reach the practitioners. We also need to focus on reaching the end users, that is a patient. So that becomes a patient centric or a participatory research concept. So here we have thoughts that say adopters must perceive an innovation as feasible. So feasibility is the key. And the other thing what is getting is, when you're messaging around, you want to actually disseminate the evidence in a manner so that it will appear to be more feasible. At least the wording is more important as well. That is another resounding or a recurring theme that is happening in these chats. And just there is another one question. Anyone else has any questions, please share it in the chat boxes. We'll be taking them up. This was another question that was in the Twitter chat. Are some implementation methods best fit for clinician-led implementation projects as compared? Yes, 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 please. Hello. Whoever was speaking, I just lost you. Can you come again, please? Okay, fine. We'll wait for the person to come back. Meanwhile, we'll proceed with this question. Are some implementation methods best fit for clinician-led implementation projects as compared with implementation scientists or even organizational quality improvement? Uh, Manish or Derek, who would like to take it first?
Yeah, I'll wait for Derek's reply.
Thank you. Yeah, I mean, dissemination and implementation are really important issues when it comes to getting evidence into practice, and particularly when we look at quite a lot of work has been done in terms of dissemination and implementation of guidelines. And earlier you mentioned clear messaging and simple languaging. The way you write your recommendations and guidelines is quite important. And one of the things we found over the years in preparing guidance is making the statements around what we want people to do very clear and very straightforward. In terms of implementation, we find that, and I'll say something about it when I in more detail when I talk. We know a number of things work. Audit and feedback work, education works, but also identifying with the groups of the intended audience what they think will be difficult to change, and coming up with specific implementation advice, support, or education to support those changes are important and help improve uptake of the behavior change you want to get adopted. But behavior change is a very complex field, and there are huge numbers of theoretical approaches. And what you really need to do is to use an approach that is based on theory in order to get people to change their behavior. And you can vary those depending on what behaviors you want to change, but there needs to be quite a lot of thought into how you plan those.
My two-bit take would be when from a clinician's perspective, the moment you hear implementation scientists you get a little overwhelmed, to be honest, right? So the idea should be that any implementation project should be context specific. It's important to keep it simple. And if you
Yeah.
have a clinical problem, it should be clinician led.
Uh, Dr. Manish, we lost. You're there?
Yeah.
Yeah, fine. Yeah. So yes, so we got a nice thought on that. I just have one small addition to that. It is a continuation of what Dr. Manish said about implementation project, implementation scientists. These are the terms which are like nightmares to a lot of practicing clinicians, to be honest. The first time we hear about it, this is like, we have entered into some kind of a management discussion or an MBA class or something. But I think they are very pertinent, and understanding this the concepts of implementation, like what Derek said, the behavior change, the behavior modeling, or instituting change. Change should be at the individual level and also at the organization level, and it has to grow beyond that into the community level, and even it has to go upstream up to the policy makers. It has to reach them as well, so that they believe in the meaning of it. So what happens is, I believe in this context, as we grow, from residents to maybe, senior residents to, registrars and faculty, and then we become senior faculty. I believe we should also focus on the on areas beyond just, clinical aspects, as as learning about implementation science, operation research, health system research, and those concepts. They should be slowly accrued, so that we are creating on the downstream, and it should also be going downstream, so that as one goes through the system and they retire, they are not leaving a void. They have a they have actually a train of people who are there to take the mantle at the appropriate time. So I believe training in these aspects is also required. And these are just semantically they appear very big, but I would say that as clinicians we have been using many of the concepts in these implementation science. It's a whole area, different areas. I wouldn't want to go into the details right now, but I think training in this area is also very important when it comes into implementation science. Anyone
Dr.
have?
Akilesh, Dr.
Yes, yes.
Akilesh, I have a question from Dr. Himanshi, and she asks whether all the stakeholders, the patient, the clinician researcher, the policy makers, and policy changers need to be on the same page for generation and implementation of evidence-based practices. And she asks for our thoughts. Well, I totally agree, Dr. Himanshi. I think the whole movement of this evidence-based healthcare day is about bringing all the stakeholders together so that we have evidence which is patient-oriented and can be implemented the way it is meant to be. So totally agree. All stakeholders have to come on the same page.
Derek?
Yeah, I mean, if you're developing any guideline or wanting to change, get a new piece of evidence from, if you like, from the research bench to the patient, you do need to have a whole range of stakeholders on board. So it is important to get their views. I suppose the challenge is that if you have 10 different 10 different stakeholders, sometimes getting them to agree a single way forward can be challenging, shall we say. Often decisions in terms of guidance development are based on a consensus decision. So you always get some people, unless the evidence is really, really clear, there are always areas for or potential areas for dissent. So you can probably never please all the people all the time. It's a matter of getting most of the people on board to get most things moved in the right direction.
Yes, again, I would just want to refer back to one of the areas what Dr. Manish had shown regarding the role of vested interest when it comes into policy. They call it as, policy lobbying. where the corporate interests tend to lobby for specific policy decisions which is favorable to them. There was in 2019, Lancet had instituted an oral commission. It was an oral health commission. There was an oral health series that was on the global oral health aspects. Different countries, how they are actually handling the problem of oral health, and it talked about the integration of oral health. One of the findings of that particular series was that what was shared, can anyone guess what would be the biennial, that means 2 years proposed budget of WHO? Can anyone have a guess on that? How many billions will it be? Somewhere between 1 and 10. How many billions for 2 years of the proposed budget of WHO, that is kind of handling healthcare of around 192 or so odd members? Any guesses? Just come up with it. It's okay. It could be 1, 2, 3, 4, some billions. Fine. Without taking much time, let me tell you. In the year 2019, 20, I think 2021, it was 4.84 billion. And in the year 16, 17, it was somewhere around 4.1 or 2. So somewhere in the 4 plus billions. And in that same year, there was a corporate, company, PepsiCo, which is pumping around 12 billion before the end of 2020 in just one single country, India, for their marketing activities alone. So you see, there is a big difference in the financial, the backup that is there. So this is, the vested interest and lobbying is something that has to be handled in a regulatory manner. For this, at least we need to get the government and the policymakers on the board. Without it, just generating evidence alone would not be enough for us to influence the policymakers. We need to find policymakers who are aligning with our ideas, and we should be able to get them on board. So aligning people from the end user, I still repeat, the concepts are now growing from just evidence based to even participatory research, where the end user is also involved in the researches. Cochrane and many other evidence generating units, organizations have already instituted that. The protocols are reviewed by consumers also, before the study is undertaken, before the secondary research is undertaken. There is a consumer peer review which also happens in order to find out if it is relevant to the consumer as well. So it is the experiential persons, people who have either taken care of persons with that particular disorder, or they have experienced on their own. They are supposed to give in their review comments before the secondary research is instituted or it is commissioned. So I believe everybody should be on the board. And any other questions? Anyone is sharing any other questions? Because I could see only the public chats here. Okay. And we have come to 1 o'clock. Actually, session wise, we have a break between 1 and 2. And since Derek is already here and I have not had time to actually introduce him formally, but let me give a short introduction. Dr. Derek Richards is a former editor of evidence-based dentistry. He has seen the growth of evidence-based dentistry, not only as a journal, but as a field from its, from the beginning stages, till he retired from the field, from the journal in 2018. He retired from it, but he's still active in the field of evidence generation, conducting courses, heading evidence summaries, and there are lots more. We would come back to it, but I thought I should at least give that short introduction about him. It is very kind of you, Dr. Derek, to join us early in the morning. What time is it there right now?
It's 8:30 in the morning.
Yes, so you joined us by around 8 o'clock in the morning. That's really kind of you. And I think as per the schedule, we have a break between, for nearly 45 minutes to 1 hour. I think we'll take that break. We are going on schedule right now. So we'll take the break and we reconvene in by 1:45, if that is fine.
Fine.
Yes, thank you, Dr. Derek, and thank you, everybody. You could keep the open. You could keep this channel open. We would be streaming some of the other chats and the sessions and other things what is available with us. And meanwhile, people could just take a break and come back and join us again for a session with Dr. Derek. He'll be giving us a lecture on evidence-based dentistry. And we do have a lot of people from dental field who have also joined in. So people who have not yet joined the sessions, please spread your word around that our speaker is already there and he is just waiting to join us. So we'll reconvene at around 1:45. The room would be open again for interactions. The room will be open. We'll be active again by 1:45. Thank you. Yes. Dr. Derek?
Yeah, I'm fine, thanks.
Yeah. It was nice actually. I mean, it was a pleasant surprise for me when you had joined in at that, in the morning session itself. It was very nice of you to have joined in at that time.
No
Um,
problem.
yes, sir. So there were other aspects also. I mean, after your session, there are a couple of more questions from the JVA chat which I would like to bring up. And
Yeah, no
there,
problem.
yes. And today morning we had a few other questions as well. During the first session, which perhaps I think you missed that session. So there were a few discussions that happened during that session as well, which I would also like to bring up. So if that is fine.
That's fine, no problem at all. I'm available all morning actually.
Oh, that's really nice actually. And okay, fine. Then it's around 1:15 here right now. Where I think in another 20 minutes we'll reconvene, sir.
Mm-hmm.
Yes, fine.
Right.
Thank you.
Okay,
Thank you. Yes.
no problem.
Yeah. Derek, welcome back.
Thank you.
Yeah. So we'll just wait for some more time, for the people to join.
No problem. When it comes to starting, just get me. I just need to share my screen. Is that right?
No problem, sir.
Yeah.
Good.
Just check that works. Is that okay?
Yes. Perfect.
Good. Do you want me to leave that up now, or do you want me to go back to your slides?
No, sir. I think this is fine.
Okay.
Yeah.
It's always slightly odd when you're sharing screens because you don't see what everybody else sees, really.
Yes, that's true.
So how's the weather with you this morning?
We live in a coastal town that's called Karaikal, so we have quite unpredictable weather, just like, they speak about UK weather. So, right now it is sunny, quite good. Yesterday we had some mild showers, but
well, it's very grey here, and it doesn't look like the sun has come out. It's raining.
okay. Now here we have good sun over there. We have it. I have the blinds on right now, but yeah, I think you could see that brightness.
Bright, yes, looks bright.
Yeah.
Yes, very nice.
Yes. So I can only tempt you with that sunny weather.
Oh, we were lucky on Saturday. We had some sun on Saturday, but it's been wet since.
Yes, Dr. Sonali. Yes, ma'am. Yes, we are planning to give a citation in this regard. So then there will be a feedback that will be collected. There will be two feedback forms which you need to fill out. One is an anonymous form, and the other one is another one for getting in your certificate. So we are keeping the feedback and the certificate form separate, so that you could give your realistic feedback to us. So yes, we are planning to give a small certificate, but I think it will be happening in a couple of days or so. So yes, Dr. Sonali has joined us, and then what? We have another 7-8 minutes. Anyone else who has joined in, if you want to have some informal interactions, it's you all are welcome. We have another 7 minutes before the session is started. Yes, Derek, I had something that I wanted to ask you, especially regarding the other courses and the other training programs which are under the ambit of perhaps is it under University of Dundee or is it under Center for Evidence-Based Dentistry?
It's sort of it would be under the ambit of the University of Dundee rather than the centre.
Okay. And are there any other short programs as well? I mean, not the formal trainings, but more like workshops.
Most of the workshops I do these days are sort of bespoke. So if people are interested in doing them, I organise them, and run them. A lot of what I've been doing in the last couple of years has been linked to the postgraduate training programs in Scotland. Although I have done a couple, I think the last trip, I've done a couple in London and a couple of courses abroad. I think the last one was in Pakistan, actually. I think that's the last time I was abroad. I haven't been abroad for a couple of years, but I have done them in various locations. I've been to India a couple of times.
Yes, I saw the list of previous sessions that have happened in the website, and it's quite intriguing. So, what about funding? Okay, we have a question already here, Dr. Sonali. So, what about the funding for research work done in foreign countries like UK or US? Dr. Sonali, would you like to come on voice? I mean, it'd be nice if you would join us on voice as well. But yeah, I'll repeat the question, sir. What about the funding for research work done in foreign countries like UK or US?
I mean, I think we've been looking with trying to establish some things. There are a number of international funding agencies that will fund work, but there are quite a number of them that will fund research, but it's about finding and getting into the right cycle of when they put out the requests for funding and the funding opportunities. So there are agencies that will fund research, but it can be challenging, and you need to get into the appropriate cycle and keep an eye out. I mean, a lot of the universities in that I've had any relationships in the past have quite often had members of the administrative staff who regularly produce summaries of the latest research calls from various agencies. So I think that's one way of looking for potential research funding. But there are quite a few agencies out there. What the impact of the current pandemic will have on a lot of those calls is open to question as well. So, because I suspect an awful lot of research in many countries has been paused because of COVID, and we've seen quite a lot of research funding going into COVID-related research. So that's bound to have an impact down the line on what research funding opportunities there are, probably not in a positive way.
Yeah, that's true. So we also had a discussion in the morning. One of the questions that was related to what would be the opportunities to pursue perhaps higher studies or PhDs, and does it have any relationship to age? Is there specific age where is it only open for youngsters, or even to middle level and higher level for
I don't think there are any age restrictions on postgraduate qualifications here in the UK. When I was closely involved with the Evidence-Based Healthcare Centre in Oxford, quite a number of the people doing the master's program and the DPhil program were, so we say, more senior in their years. So it's about whether you can either fund or get funding to do the post. I suspect that funded postgraduate qualifications from various universities and would require a younger individual. But if you were self-funding or had funding from other agencies, there doesn't appear to be a restriction.
Yeah, speaking of funding, I had a specific question myself. Perhaps we do have a lot of funds which are, and I wouldn't say a lot of funds, but yes, funds are usually earmarked for intervention trials or for community trials. These are two areas where it's comparatively easier to get funding. But what about the secondary research? The evidence generation, like say, even when it comes into a systematic review of meta-analysis, it's not it's not always economical. Sometimes we need to have access to commercial libraries, which how easy is it to get funded for that?
I think it's particularly difficult to get funding for secondary research. Sometimes for larger projects, there's a need to do a systematic review of the area that's being the questions that are being addressed in order to go to the next stage of funding. So sometimes it is possible from some agencies to get some, if you like, seed corn funding in order to do a piece of secondary research which would inform the development of the full research project. So if one hasn't already been done, and it would need to be a new there would need to be a need for a new systematic review if one hadn't existed. But the opportunities for those are few and far between, I think, because most people think that doing systematic reviews is a cheap project, but it's not cheap either in time or, as you say, resources for secondary care. I mean, I suppose one option is to do something like a Cochrane review, where Cochrane would help source the primary publications for you to, in order for you to do the review. So that's one way in if you wanted to go down that route.
That's true, sir. Yeah, I think it was the same thing, because when I was there were a couple of calls. Some institutes, like say even ICMR for India, at some point they had given specific calls for secondary research, for systematic review and meta-analysis. But as you mentioned, these calls are few and far in between compared to the other, they call grant proposals which come up. What I have actually noticed, one more aspect is regarding environmental health. There are a lot of agencies which are working on environmental health, and when they want to generate evidence, much of the evidence is based on the secondary research. So we have, funding sources in those domains. Whereas when it comes into healthcare, even I was at loss, because one of the EPA's document was giving a breakup of the the economic breakup of running a systematic review and meta-analysis, based on the time spent and the value that is there. So the project is very well, it requires funding, but like you mentioned, it's not common to, it's not easy to get it through unless it's part of a larger project.
No, it is a particular challenge.
Yes. Is it okay if we wait for a couple of more minutes before we start, sir?
Yeah, no problem.
Dr. Sonali has put up another question. If we compare the dental practice in India to that of in UK or US, what are the differences that we can see in terms of safety precaution for infectious disease? Is there any better method that we can adopt?
Are you thinking in specifically in relation to COVID, or just generally?
Dr. Sonali, is it specific or in relation to COVID, this situation, or would you want it to be more? Is it a general question?
I'll make some specific some general remarks anyway. I mean, I think what we found in the UK here when we had the last big push about infection control in practice, it was a lot of it was about procedural issues within the practice as much as the equipment. So it was about making sure the workflows were appropriate. From you had an orderly transition from clean to dirty instruments, and ensuring that instrument checking was done before decontamination, and then storage of instruments after that. So, and using the right disinfectants and solutions, and it was almost more about process than it was about what people were doing, and ensuring those workflows were smooth and well, and people didn't break the chain. So a lot of it was about that. There were some elements to do with improving the quality of equipment in terms of decontamination and washer disinfectants, but generally it was most of the improvements came from improving workflows.
Yeah, just to add a point for India, I think this is an area where there are certain gaps in certain areas. One is regarding the infrastructure, sometimes it's regarding the equipment available. So resource constraint, in any of this is the same resource constraint we face in many of the lower and middle income countries. And, with respect to safety precautions for infectious diseases, I believe some of the simplest methodologies are the ones that work best. I think even Derek would agree to that if I'm right.
Yeah, absolutely. I mean, I think although most of the recommendations were process related, they were about ensuring those flows from clean to dirty instruments, and the processes for cleaning them, ensuring that they were followed really within the practice, and having clear protocols within the practice for achieving them, because the same, at a different level, the same constraints apply. There's always a resource issue because dentistry is quite often a high investment, low profit type business. So, it's about striking a balance between ensuring the lowest level of cross infection with the level of resource you put in to prevent it, because the biggest benefit is normally from the simple interventions. As you increase the costs for the smaller additional gain, it's probably not that important. So it's about getting the basics done properly first, which will probably give you the biggest reductions or improvements.
There is one a small question that I wanted to add up on the funding. I mean, it's funding in relation to the practice, it's not the research funding I'm talking about. So since your specialty, sir, is in public health and public dentistry, so, I was just wondering, is it the same practice like the Oral Health Commission of the Lancet? They had a common theme that was coming up where oral health was getting a very low priority in the national health policies of a lot of countries.
Mm-hmm.
So, we would like to hear a small comment of yours in that.
It's always been a challenge, I think. Even if you look at even in the UK, where it has got quite a sophisticated dental market, if you like, the spend on dentistry is about 5% of the spend on healthcare, and that's both private and public spending. So it is a small element, yet it is a significant disease. The two main dental diseases. So we have a huge disease problem with two highly preventable diseases, a huge amount of budget spent on it in terms of, 5% of the budget is, we don't spend 5% of the healthcare budget on any other single disease. So it's pro rata, it's a huge disease. And getting recognition of the impact has been quite challenging, and it remains challenging. I think some of it's dentistry's fault, but we are at one level we want to be in with healthcare, and at another level we always want to be seen as separate. So it's getting full recognition of dentistry as a key element of healthcare is very important. And I think the Lancet series is one opportunity of raising the profile of of it. And I think the work that the WHO do as well is also very important in raising the profile of dental services, because it causes an awful lot of pain, distress, and disease across the planet. I mean, it's a huge impact.
Yes, sir. I think we will start the formal session.
Okie
And
dokie.
yeah, and I know we are doing it a little, the upside down manner where we already have you interacting, and now I'm going to formally introduce you. Okay. Anyway, so we have Dr. Derek Richards already. He was joined us in the morning session, and right now, so he's the director for Center for Evidence-Based Dentistry. And he's a specialist advisor to the Scottish Dental Clinical Effectiveness Program, and he's a specialist in dental public health. And right now, associated with the University of Dundee as a senior lecturer. Derek qualified from Cardiff Dental School in the year 1977 and entered dental public health. And since then, he took some real interest in the field of evidence-based healthcare, and he helped establish the Center for Evidence-Based Dentistry and for the Journal of Evidence-Based Dentistry, which he edited until 2019. So Derek has been involved in the York review of water fluoridation, the NICE dental recall guideline, and the SIGN guideline on the prevention of caries in children, and a number of guidelines and other projects which have been associated with the Scottish dental. Oh, we have a kid joining us as well, I believe. Okay. Anyway, fine. So in 2011, he established the Dental Elf website, which he edits. And Derek is formally retired from his NHS consultant post in 2019, but he's still leading the Center for Evidence-Based Dentistry and is still active in conducting workshops. And he was really gracious that all it took from me was just a message, and he agreed that he would want to be part of it. So that's really nice of you, sir. And I would just leave the stage for you right now, sir. Thank you.
Thanks very much, and thank you very much for the kind invite. It's not always nice to receive invites. Okie dokie. I'm going to talk to you about give you an overview of evidence-based dentistry, and this is very much a personal view from my sort of 20 years experience at providing in evidence-based dentistry, and I'm going to look at why we need it, what is some of its successes from my point of view, and the challenges that we face going forward. So I'm going to start off with a definition, and I think everybody knows there are sort of three main elements. We need good clinically relevant scientific evidence. There's the dentist clinical expertise and the patient's treatment needs and preferences. And it's sort of a triad of best available evidence, clinical experience, and patient values. And ideally where we should be practicing is within the evidence where all these overlap. In terms of why we need it, it's probably not really that new, because I think the best practitioners have always wanted to base their treatments on the best available evidence. One of the problems we have these days is that information overload, and I'll come back to that. Increase in the last couple of decades, we've had an increase in focus on the quality and consistency of delivery of healthcare, and ideally to avoid unnecessary treatments which do have more harm than benefit. We've increasingly questioned our traditional training and beliefs. As the volume of knowledge that we have has increased, there is a recognized need for lifelong learning and development. We also see that, particularly with the rise of the internet and access to the internet for lots of people, there's lots of information out there, and patients are much more aware of treatments and procedures, and if they want to, they can usually access most of what we as dentists can access. And last but no means least, their resources for providing healthcare, and dentistry in particular, are finite. So if you think about the information overload, just last week I put the term dental into Google and I got 900 million hits. Even on Medline, there are more than 500,000 dental references. And in the more specialized databases like the Cochrane Library, 200 reviews and 50 protocols and 25,000 randomized controlled trials. That's a significant amount of information. Looking specifically at dental reviews, we can see since the 1990s, when about the evidence-based healthcare movement, sort of an evidence-based healthcare really became recognized. We've seen a large increase in the number of reviews and a similar increase in the number of dental randomized controlled trials. You can see about 2,000 trials. So that's if you're reading 40 trials a week, if you wanted to keep up with the latest across the breadth of dentistry. So a significant amount of information. And the challenge is getting what is valid research to the patient. In order to do that, we as practitioners need to be aware of the research. We need to accept the findings of the research. It needs to be applicable to our patients. It may not be. We need to be able to provide that treatment if we can. That might need additional training. And even if we have all those things in place, we then have to act on that evidence. Now, in order for us to act on that evidence, the patient needs to agree. And if they need to follow any recommendations we make, or the evidence recommends they make, they need to stick to it. So they need to comply in order for us to get the outcomes. So at each level here, we have barriers, and these barriers mean that there are leaks in the evidence pipeline. And even if we are just 80% successful at each of these barriers, we would only, if you do the mathematics, we would only get 20% of that valid research down to the patient, which is about where we are and where we've been for the last number of years. Ideally, what we're striving for, and this is from Muir Gray, who was one of the early pioneers of evidence-based healthcare, he said what needs to happen is we need new knowledge and new technology properly assessed and managed into our healthcare systems or into our personal practice. But there are essentially two major bypasses. There's knowledge bypass, and that's the new evidence, if you like, going straight past the system and not getting integrated. And then we have technology. We're all fond of introducing technology without it being properly evaluated. And I suppose within dentistry, we've got a really good example at the moment. Cone beam CT is a very useful tool, takes very nice images, but we don't know how that should be best integrated into practice because it produces a larger load of radiation. So how that's best managed in and where it's best used still needs to be properly assessed. So evidence-based practice is a system, if you like, for integrating, distilling and delivering the best clinical evidence. And there are 5 processes, really. We need to ask good clinical questions. We need to find the best evidence to answer those. If we can't find it, we need to do the research. We need to appraise that critically, apply that evidence, and then evaluate the outcome. These are the so-called 5 A's. And to me, these are the sort of things we should be teaching in dental school. So that's a quick run through of what it is and why we need it. And I'm just going to cover some of my personal views of what I think the successes are. And I'm going to kick off with the Cochrane Oral Health group, which are one of the groups from the Cochrane collaboration. It was established very early on, shortly after the formation of Cochrane itself. And as I mentioned earlier, we've got over 200 systematic reviews that have a dental connotation, and there are 50 protocols. And it has a high impact factor, and they produce high quality work. We also have the Cochrane Library, which has all the Cochrane reviews in it, and it has a large database of randomized controlled trials. It also produces things like clinical answers, and has links to other resources like the Cochrane Handbook, which are very useful tools if you want to do systematic reviews. As well as the Cochrane Oral Health Group, there are a number of other centres that have been established over the years for evidence-based healthcare, and these are just in alphabetical order. You've got the American Dental Association, one in Chicago. Cochrane we've already mentioned. We've got the centre that I run in Dundee. Egypt, there's one based in London at UCL. There's one in NYU and one in Wuhan. There are probably lots of others as well. So groups working on evidence-based approaches within dentistry. In addition to that, we've seen the establishment of a couple of dental journals. I was involved in the Evidence-Based Dentistry Journal, and then we have the American one, which is the Evidence-Based Dental Practice. Both of these produce summaries of the high quality dental literature, which helps reduce the time we need to read the more detailed documents. Other tools produced by other organizations that are useful are the Critical Appraised Topic library that the University of Texas produces. This is updated regularly, and they've got a couple of thousand documents on now. It's produced by dental students with support from members of staff, a useful tool. We've already mentioned the Dental Elf. One of the problems I found with the journal was that it only comes out once a quarter. Information slips by. So we started producing the Dental Elf, which gives you little summaries that link to slightly longer summaries between 800 and 1200 words of the latest higher quality evidence. This is part of a larger group, a national service. All the summaries are free, but there are some additional benefits you can subscribe to if you wish to. Another very useful tool is the TRIP database. This is one of my favorite searching tools. This is, if you like, is Google for healthcare research. That's how I like to see it. It has a very effective search strategy, provides evidence linked or in a structured manner, and a very useful tool. Again, basic searching is free, but there are some additional benefits that you can purchase. As well as evidence-based evidence-based journals, tools, and books. We've also seen a large increase in number of evidence-based guidelines. These are 4 organizations that have a highly developed guideline production process based on the NICE system, and they've produced a number of dental guidelines. In addition to that, we've seen large numbers of guidance documents produced by individual dental specialties, specialist societies, and specialist groups. So there's been a large increase in the number of evidence-based guidelines. Another very helpful development has been the development of reporting guidelines for different types of research. The very first one of these was the consort one, which is about how to report randomized controlled trials, PRISMA for systematic reviews, QDAS for diagnostic studies, and STROBE for observational studies. This helpful website called Equator Network summarizes them all. So if you're, while this is for reporting guidelines for study, various different study designs, it's quite useful if you're interested in doing some research in a particular area, because if you know what you should be reporting, helps you design studies in the first place. We've seen in dental education, the GDC in the UK has made evidence-based dentistry a curriculum requirement, as have CODA in America. So critical appraisal skills have been incorporated into many, for all of the UK dental postgraduate exams, and into many undergraduate and postgraduate curricula. So there's been a big increase in the recognition that evidence-based dentistry is required in dental education. We've also seen questionnaire surveys of attitudes to evidence-based dentistry. This is just one from a large study that was done in Europe, and most respondents believe that evidence-based dentistry approach is beneficial. Although while there's been a positive attitude towards evidence-based dentistry from most practitioners, there is a recognized need for more information and support in being able to practice in an evidence-based manner. So I very quickly outlined why I think we need it, what some key successes. They're not the only successes. But I'm going to talk now about some of the challenges as I see it. I think people will be familiar with this hierarchy of evidence with systematic reviews at the top. And I've shown you that we've had an increase in production of systematic reviews in dentistry. We've also had an increase in this unfiltered level of randomized controlled trials. But if you look at what's published within dentistry generally, an awful lot of what we currently do is still down at this level in the case series and case reports. So there is a need for better quality primary and secondary.
I didn't catch that. Could you try again?
Go away. Sorry about that. Don't know why Siri suddenly sparked into life. So we've got this well-known hierarchy of evidence, which is meant to be related to implementation studies. Increasingly, there's a recognition that hierarchical systems are not the only approach, and we need to take a broader view because the type of evidence we need to answer a particular question varies. So we don't always need randomized controlled trials. It depends on the question we're looking at. And often the answers to, when we're developing guidance documents, for instance, often we need to take not just the evidence of effectiveness into account, but also information on harms, and that might come from observational studies, for example. So we need to think more broadly about the type of evidence we need to produce and to use in order to improve the delivery of evidence-based dentistry. Just looking at some examples of work that's been done, looking at the quality of research within dentistry. If we think about, this is a piece on dental guidelines, and we can see one of the problems is that guidelines within dentistry generally are suboptimal. If you use the AGREE appraisal instrument, we can see that the dental guidelines don't always score well. This is a 15-year summary of guidance documents, or guideline, which has shown some improvement over the period, but still a suboptimal level of reporting. This is an example of a specific specialty. They looked at 25 guidelines over almost a 20-year period. And what we see here is that they were of low overall quality. If you look at the image here, you can see these are the elements of good reporting practice that weren't reported. So it's quite a lot of the more green, the better. So you can see that almost 50% of these didn't have enough green in them, really. So it's about what we report and how good our guidelines are. So low overall quality. And most of these guidelines are talking about the methodological approach to reporting these guidelines rather than the underlying evidence. So it's about the methodology for delivering them rather than the evidence on which they're based. Looking at systematic reviews, this is a piece of work that looked at 200 meta-analyses using the AmStar tool for assessing their quality. And we can see only 22% of these were of high quality. And another quarter were of low quality. A lot of work goes into doing a systematic review, as we were talking about before we started formally. And to produce a low quality systematic review takes almost as much effort as to produce the high quality one. So we need to improve what we're doing. This is a later piece of work done a couple of years ago. This just looked at the number of systematic reviews which were published in a single year in a number of journals. And you can see almost 500 systematic reviews. That's quite a lot of systematic reviews. Of 13 of these were Cochrane. Of the non-Cochrane ones, there was a highly variable reporting quality. So there is still a need to improve the quality and reporting and conduct of systematic reviews in dentistry. Looking at the primary studies now, and I'm just using orthodontics here as an example. I'm not specifically picking on it. If you look at other specialties, you see a similar picture. They looked at over 300 trials. What they'd seen over the decade was an improvement in identifying a study as randomized, improvements in defining what the sample size should be in the first place, better descriptions of blinding and the randomization process, but still a need to follow consort guidelines on reporting randomized controlled trials more closely. And there have been moves more recently in orthodontics for some of the journals to not accept articles if they don't closely follow consorts and offer a pre-screening of papers, as is offered in the BMJ in relation to consort alignment before, and potentially giving people a better opportunity for publication in that journal further down the line. The other issue that is an important element is about how patient-focused we are. We saw that one of the key elements of the evidence-based approach is the patient's needs and preferences. If we don't take patient outcomes into consideration, we can't. It's very much more difficult to see what their views and opinions are. So we can see here that only a third of the studies that this Patrick Fleming's group looked at here had a patient-focused outcome. So we need to think more about involving patients, because at the end of the day, they pay for dental services, whether it's through their taxes or directly or indirectly through insurance. So having patients on board is vital for the future development of dental services. One of the things we're trying to do, if we're trying to bring new evidence into practice or get people to adhere to guidelines, quite often it's about changing practice. And there are some recognized barriers to changing practice. There's knowledge and attitudes of practitioners. We're all faced by this information overload. Often we have there might be some clinical uncertainty because the particular presentation in our practice might be different from what's in the literature, for example. Opinion leaders can be quite powerful in proposing the types of things we should be doing. Often people, if they don't follow a lifelong learning pathway, that not our knowledge can become out of date quickly, more quickly in some areas than others. There are a whole range of patient factors. The practice environment, it can often be challenging for adopting new behaviors and new practices. There are challenges sometimes within the educational environment, in both at an undergraduate and a postgraduate level. Not only within dentistry, but within the broader healthcare system, there can be challenges quite often in relation to the funding systems that are applied and a lack of support for innovation and the adoption of new practices and procedures. And we all now live in a much more connected world, as this webinar shows. You know, media influences, commercial influences, they come at us from all directions these days. There has been some work on dissemination and implementation strategies, number of systematic reviews done by Jeremy Grimshaw and his group, now based in Canada. They've looked at a whole range of interventions, and these three consistently provide some changes and improve implementation. Education, which is related to what you're trying to achieve. Audit and feedback about specific compliance with the procedures, and regular reminders. But there's still an awful lot we don't know, whether multifaceted interventions are better than single ones, how much it costs to do these things, which strategies work best in different contexts. And an awful lot of the work has been based in developed countries. So low and middle income countries, will the same things work to the same degree? And only a small number have been conducted in dental practice. We've done a number in the UK here, which show that audit and feedback work quite well, supported with reminders. This is just to show you how complex the behavior change literature and landscape is. It's more for the impression rather than for you to read. because the theories around behavior change are complex, Susan Meeke in UCL has come up with this sort of summary of what they think are the key behaviors, the capability, motivation, opportunity model, which all affects whether certain behaviors are adopted. And using this model, we have looked at, this is what we use in our Scottish Clinical Effectiveness Program when we are developing new guidance. Again, I don't look in detail at and read this slide in detail, but the pink areas are the steps in guidance development, whereas the bluer areas are the diagnostic pieces of work that we do on trying to address which behaviors we think need to be addressed, which behaviors the practitioners themselves think will be challenging to change, and we develop education and implementation support to go with it to improve the uptake of our guidance documents. Another big challenge we have is research waste. It's been estimated that 85% of research is wasted by addressing the wrong questions, not using the best design to answer those questions, and either not publishing or poorly reporting the findings. A recent piece of work showed, for example, that less than a third of IADR abstracts presented at conferences ever get published in full. So that gives you some implication of the potential waste of those projects. And a lot of studies in medicine have shown that it takes 17 years for research to be translated into practice. If I give you an example from a dental piece of work, we mentioned that I was involved in the NICE guidance on dental recalls. Following that, and because of the lack of information, there was a lobby to get the national institutes in the UK to fund some randomized controlled trials in primary care into that. The initial document came out in 2000. The research that was eventually commissioned as a result of that call has only just been published. So that's 20 years. And that's just publishing the research. That's not actually getting it then into practice. That's the next stage. So that's liable to take a few more years. Because research is wasteful, John Ioannidis came up with these features to consider when in appraising whether clinical research is useful. And I think they are important questions that we should be asking when we're doing research. So you can see there's some things about the patients here, value for money. Can you do this research? Is the problem important? And has there been a systematic review done prior to it? Systematic reviews done prior to research are very useful from two perspectives. They can identify gaps that need to be addressed, and they can also give you a steer on what questions you need to ask to either provide support to that evidence and to fill in gaps that you need to address with perhaps different types of research in order to give you the best answers. Because of all this research waste, one suggestion of how we deal with this is to develop evidence ecosystems. And this is one that involves the Cochrane Oral Health Group, where they look at producing what the evidence is produced, synthesizing that, disseminating and adapting it into guidance, and then implementing and evaluating that to generate new research questions and completing the circle, if you like. A large group of people involved in this, and it has potential, but there are still challenges within this line of approach. If we are to deliver high quality, efficient care, we need to look at reducing overdiagnosis of disease, over-treatments, and underuse of effective interventions. We've got good evidence, for example, for preventive dentistry, but in most healthcare systems, we often treat rather than prevent. And that's just one example. We need to address, there's been a huge increase in research and dental guidelines, often repeats. If you look at periodontology, for example, there are a huge number of systematic reviews in periodontology, often repeated at very short intervals, and most of them say that they need more evidence. My view would be that we need to go back and ask those primary research questions and address them in well-conducted large-scale studies. Then guidelines can become more useful, increasing their value and reducing research waste. I want to just say a quick word about the impact of COVID. What has been interesting has been rapid review methodology. It has been resisted by Cochrane and other systematic reviewers for a number of years because they think that detracts from the process. But what has been interesting during the last 6 months, because rapid reviews have been completed and they have been to a high standard in a short period of time, largely through interdisciplinary and broader collaborations within any particular scientific field and the willingness to share data. Now, whether these are good positive signs, whether they will be continued after COVID is another issue. And we've managed to produce 3 good reviews within a 6-month period, whereas normally to produce a document like this mitigation of aerosol generating procedures document, that typically it takes SDCEP 2.5 years to produce a document to this level. This was produced in 9 weeks. So you can see the 9 very hard weeks, but it can be done. So we could increase the speed of review production. So just to close, over the past 20 years, we've seen an increased awareness of evidence-based dentistry, greater availability of information to support evidence-based dentistry, large increases in the number of trials, reviews, and guidelines. Although, having said that, their relevance to patients and primary care practitioners needs to be addressing, as does their quality, both methodologically and their reporting quality. And we still face large challenges in how we disseminate, implement, and educate practitioners in evidence-based approaches. Okie dokie. I'll stop screen sharing.
Yes, sir. We have around 10 minutes for discussions. Dr. Derek, it was an amazing presentation. It was summarizing the whole path of evidence-based dentistry from its inception till what is the current status today. And we have around 10 or 15 minutes before we need to wrap up. I just got a message that they have a meeting that is scheduled at around 3 or 3:05.
All right.
So we'll just quickly run through a few of the questions we have. And audience, if you have any specific questions, please do share. So one of the questions that was there in JBI's Twitter chat today was, often we hear that research evidence doesn't take into consideration the specific circumstance of localized settings. So, how do you examine and prepare your context for readiness for evidence into practice? Yeah.
I think one of the I think there are a couple of issues from a dental perspective. We've got two diseases which are fairly common: caries and periodontal disease, and that if the diseases are very similar, I think perhaps the contextual issues are not quite, in terms of treatment approaches, are sometimes not quite so important as they might be. That's one point to bear in mind. The other point to bear in mind is to make sure that when you're designing and developing your studies, you involve the practitioners on the ground. So we've done a number of pieces of research in Scotland, Jan Clarkson has led in Scotland, and we've always involved primary care practices, which makes the research much more grounded, if you like, because you have the practitioner's perspective, both in the design and development of the study and in the delivery of it. So they become much more generalizable.
Yes, there was. Yeah, this was another question that was there. Facilitation is an integral component of getting research into practice. What examples of successes and failure of facilitation can you suggest? Or is facilitation linked with sustainable change?
I'll give you an example from one that we've done recently in Scotland. We for a number of years we've been producing guidance documents on antibiotics to reduce prescription of antibiotics. We've recently done a randomized controlled trial where we've looked at all specific audit and feedback to practices in order to reduce their antibiotic prescriptions. That was coupled with specific training as to why they should be doing it. So you had the interventions involved training, audit and feedback, where they both at a practice level and a regional level. So people got what their prescribing habits were, what their colleagues were within a region, and what the national. So they got this data given to them every 3 months initially. As well as doing that, we were given specific feedback. So the trial also involved feedback onto alternatives to antibiotics, alternative antibiotics. So we're hoping to move them from a broad spectrum antibiotic to a narrow spectrum antibiotic. And what this the trial showed, just by sending them information, so it was we saw between 7 to 14% reduction in antibiotic prescribing over the trial period, and that's been maintained since, because we have access to prescribing data for practitioners. So we can, up until the COVID outcome and the change in or restrictions on dental practice, we had seen a marked improvement or reduction in the level of antibiotic prescribing. So that was one positive benefit. And but on a negative, we've looked at fissure sealant use within practice, and that even with an additional payment, that didn't make a difference. So we were getting paid an additional fee for putting on fissure sealants, and that didn't change behavior. And when we looked at that with a qualitative piece of research, what we found is that was because practitioners themselves did not believe that fissure sealant worked. They were worried about loss, and they were worried about caries under the sealant. So we've tried to address that by looking at the research, but we still haven't managed to get that on board. So that's still a challenge. So there's a positive and negative example there.
So this is another question. I think we will, if audience have any question, please put it up in the chat box. And I was trying to share a feedback form I believe there is some problem with the form. If it's not accessible, then the form should be shared with you over email later, so you can come back with your feedbacks on that. So meanwhile, let us make the best of our speaker here. The other question is, what advice would you give, sir, for a health professional who is new into evidence implementation? Especially with respect to dentistry.
Oh, that's a big challenge. I think one is whatever you're trying to implement, you need to have your practitioners on board. So you need to you need to look at what information you're trying to implement, and what the local delivery of your local practitioners are doing. So you need to know what their position is in order to get things changed. Then you need to look at unfortunately, you do need to look at changing their behaviors and what approaches. So one opportunity would be to get behavioral change people on board within your team. So people who've had experience of behavioral change, and that could be behavioral psychologists or specialists in implementation science. So having advice from them is key, but it also needs to be context specific. So you can't always take a tool that has been used very well in one area and use it exactly the same tool in the other area. Quite often you need to contextualize that and get working with your local practitioners, make it appropriate to the group that you're trying to change. So it's about almost personalizing it. And it's about that level of personalization. Sometimes it needs to be very, very specific. Other times you can step it back a bit, so it doesn't need to be, you don't need to change it too much, but the messages need to be simple as well. And it needs to be practical within any given environment.
Yes, that's totally true. So I had a personal question. It was regarding the economic evaluations you're mentioning about. Even I've been quite seeing the gap in the literature available, where because economic aspects are the ones that drive policies, whereas we do not have economic information in most of the researchers. So the policymakers do not know how much does it cost for them to implement a particular program, or what is the cost that they would incur. So there are frameworks in health economics research and outcomes research when it comes into field of medicine. Do you think those methods are enough to be applied in oral health, or do you think we would need a slight differences in the framework or in the in that area?
There probably needs to be slight. I mean, what health economic appraisal or studies in dentistry are very, very thin on the ground. Often, and you need to have a good quality. You can sometimes retrofit health evaluations, but it's better if you design the economic evaluation into the study in the first place. The downsides about that are it increases the costs of the research in the first place, because you need to have a health economist inputting then to do the data, because the health economic analysis can be quite challenging. You can do very basic pieces of work. I'll give you another example. When we did the sign guideline on, and one of our recommendations was that you should fissure seal all permanent molars when they came through. There was a big question mark about would that, because sign has a policy that if it's going to increase healthcare costs by more than X million, you need to do a formal economic analysis. So we had to do an informal appraisal of the impact of what of fissure sealing or permanent molars would be. It was relatively straightforward because we knew we have good process data on what's already being done. So we could make a number of assumptions based on what was being done, and if that translated from not just first permanent molars to second permanent molars. But that's a very basic calculation, and sometimes those can be helpful, but they no means completely replace a proper health economic analysis. And we need more of them in dentistry, because dentistry is expensive to deliver in most places, most of the time.
So you feel the general, the general health economic methods and systems in place would be sufficient for oral health, or do they need modifications?
Most of them are based on other economic evaluations, so that you can use the similar methodologies. So it's you don't all you need to ensure is you take into account all the relevant inputs and outputs. But the basic healthcare methodology should be sufficient. So you don't need specific dental healthcare economic analysis. We just need to do them.
Right. So we are coming to the close of the session. We are running a little short on time. I just have two closing remarks to the audience here. My email has been shared with you during the sharing of the link. So, the questions can still be sent over email for the next 3 or 4 days. We will curate the questions and send it to the speakers, and which they can answer at their convenience. So, in the next couple of weeks, we could have more interactions in this regard. So that's always there. And regarding the feedback forms, there are two feedback forms which will be shared with you. One would be an anonymous feedback form regarding the sessions, and the other one would be to collect your details for any citations which you would want to give it to you for the attendance. So please do take your time to fill them up. I will share. I think the link which was shared is not opening. I'll sort out the issues and I'll share it with you later through the email at a later time. So please bear with me for that. And if there are any other questions right now or any other feedback, we are open for it regarding the whole session, or if there is anything that you want to share on this evidence-based dentistry. Anybody? You could just unmute and give your view. Do a quick one because we have less than 2-3 minutes before we need to wrap up. Okay, fine. So, Dr. Derek, it was really, it was a very nice having these interactions. Perhaps I think we should have, had a marathon session, instead of we breaking for lunch. There would have been, we would have had more opportunities to interact. But I think since we are already in touch, and I would make sure that whatever questions are coming in this regarding this particular topic, I would put it forward to you through email.
Okay.
And you could answer it at your convenience, sir. And in fact, there were a lot of people who were interested in the research activities, further education and research. These are some of the questions which we handled during the beginning of the session. So I believe we will have a few more questions in this regard. And for the information of all the oral health people here, the oral health policy is in a draft stage in the for India as of now. So we believe India would be coming up with a formal oral health policy at some point in the near future. So let's look forward to it, and let's hope that there is more scope for integration with general health, which is the universal call all over the world, that oral health is supposed to be integrated with general health and aligned with the general health programs and the other national health policies. So with that, I think I'll just wait for 1 minute. You could quickly put in your comments in the comment box. It's really nice when we see the live comments. So please do give us some live feedback as well.
Yes, thank you very much.
Yes, sir. Thank you, sir. And really grateful to you for having consented and joined us. And I believe we will, we would like to have you, more often, on more pertinent topics or specific topics. Now, this was a very short notice, so perhaps the next time we would plan it ahead, as a proper session at your convenience. I believe it will
Okay.
be okay.
Yeah. Yeah.
Hmm. Yes, there is a YouTube available. It'll be recorded, and the YouTube link will also be shared to all of you all through your email. So yes, I think at this point we are at the end of the session. So thank you all. Thank you all the participants who have made it a point to join and share your thoughts and be with us throughout. And people who have made it back after lunch, I am really thankful to you. It's not always easy to take a break and come back to a session. So Dr. Himanshi has a question, sir. Any online training opportunities at University of Dundee for evidence-based dentistry?
Not unfortunately, not at the moment. But
So yes, Dr. Derek, then perhaps we could suggest, would you, would university be interested in such an opportunity? If that is the case, we would be interested in collaborating.
that's a very kind offer. I'll speak to my. I do sessions on evidence-based dentistry, and it has been raised. So it's it's a case about keeping my wife happy now I'm retired.
Okay, sir. All right, fine.
But
Right, so then,
in principle, yes.
right. Uh, okay, I think we will need to wrap it up because I think there is another meeting coming up. I'm really sorry, guys, that we're not able to have a longer discussion. But you could still send emails, and the feedback links will be shared with you through the emails. And please do make it a point to fill it and send it back. And your questions are welcome. We will still get back to the speakers in the post session and try to curate your questions, get your answers, and get it back to you. We'll get all the answers together and send it back to you people. Thank you.
Thank you.
Yes, sir. Thank you, sir.
Thank you.
And thank you, everyone.